Test one, two. Check. Check one, two. Can you speak something, Ramu? Manu? Hello? Hello, check one, two. Hello. Hello. Can you testing your mic, please? Hello. 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 Yes, sir. Hello. Hello. Can you hear us? Hello. 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 Yes, yes. Your voice is clear? Hello. Yes, yes, it's clear.
Hello, we are from OT here.
Yes, sir.
Audible clearly?
Sir, yes, sir, it's audible, sir.
Okay, can you please show the screen there? Can you focus on the screen there? Can you zoom in? Is the visual clear there?
Yes,
From
sir,
here we are seeing.
Sir, yes, sir, it's very clear, yes.
Okay, thank you.
I request all the dignitaries to please take their positions and have a seat. Final year orthopedic resident, and it is my privilege to welcome you all to the Orthopedic CME 2026. Indian Arthroscopy Society presents joint preservation program organized under the auspices of Tamil Nadu Orthopedic Association, Cholamandapal Orthopedic Society and Puducherry Orthopedic Society. Today, we are gathered here for a continuing medical education event and workshop focused on joint preservation program, the knee joint. I extend a special welcome to our extreme dignitaries on and off the dais, our distinguished guest speakers from various institutions, the heads of departments, faculty members, and my dear colleagues. Thank you for being here, and I look forward to an enriching and a productive program. So we will now begin with session 1. I now call upon stage Dr. Gopi Shankar Sir, Professor, Department of Orthopedics, JIPMA, and the chairperson, Dr. Rajagopalan Sir and Jaikumar Sir.
So very good morning. At the outset, I would like to thank Dr. Manikandan and the organizing team for inviting me for this meeting. So my talk will be on clinical assessment of a patient with knee instability. This is a very basic talk, particularly for the postgraduates. So to start with, history taking and clinical examination are the pillars of clinical medicine. So even today, clinical skills are very important for accurate diagnosis, clinical reasoning, and of course, building trust with the patients. A thorough history opens the door for diagnosis. If you take good history, you'll be able to reach at least 60 to 70% of the diagnosis. Physical examination just helps in confirming the findings and to assess the disease severity. So coming to history, these are the common complaints patients come with. First is pain, swelling, instability or giving way, stiffness or reduced joint movement, locking. Out of which pain is the most common symptom. So coming to mechanism of injury, it is very important to know how the injury happened, whether it is direct, indirect, high energy or low energy, because this will give an idea of which structures are injured. Usually knee instability is secondary to trauma, so it is important to know when the trauma occurred, whether the patient was able to weight bear immediately, did he or she resume back to play. If they is not able to weight bear, it means patient has got a significant injury to the knee. And also it is important to know what treatment they had initially, whether they had any splinting like brace, any knee aspiration, whether they underwent physiotherapy, post-treatment and all those things. Coming to pain per se, it is important to ask the patient to localize the site where he has got the pain and what are the aggravating and relieving factors. And you have to differentiate which is mechanical and rest pain. Mechanical pain is usually following loading. Rest pain usually seen in chronic cases, it can be because of inflammation, infection, or sometimes even arthritis. Swelling, the swelling is immediate. This is usually secondary to hemarthrosis, which indicates again a significant intra-articular injury. If it is late, it is usually a synovitis. Coming to instability, you have to ask the patient what are the activities which cause instability. Particularly, patients will have instability, for example, in ACL tear, they will have instability while running, jumping, or pivoting movements. Instability can be due to not only ligament injury but also due to extensor mechanism weakness, neurological problems, and sometimes periarticular non-linear malunion. For example, a malunited tibial plateau depressed fracture can even cause instability. Just see this video. What is this? Anyone? This is classical locking. Patient will not be able to extend fully and he has to maneuver his limb and do the full extension. This is classical locking. He will be able to do full flexion but extension will be difficult. So locking is typically caused by pachydental meniscal tear and loose bodies. Sometimes even free cartilage flap can cause locking. Sometimes muscle spasm and patellofemoral arthritis may also mimic locking. See these two videos. See what happens during the terminal extension. There is a small snap happening. So this is called snapping, popping or thud. typically happens in discoid meniscus. Coming to examination, general examination, it is important to look for ligament laxity. Gait, in a patient with only ACL tear, usually the gait is usually normal, but those with associated meniscal tear or significant intra-articular injury will have a antalgic gait. If a patient walks with this mild limp and a minimal flexion deformity, you should suspect bucket-handle meniscal tear. Coming to inspection, look at the alignment, varus or valgus alignment. If it is valgus, you should think of even patellofemoral instability. Look for any flexion or recurrent deformity, parapatellar fullness, posterior sag, ecchymosis, again will give an indication where the injury is. Usually MCL tear and all this thing will have more ecchymosis on the medial side. And of course, any injury to the knee will have quadriceps wasting. Palpation, look at the joint line tenderness, feel for the femoral epicondyles, proximal tibia, fibula head, and of course patellar tendon and quadriceps tendon. Swelling, if there is minimal swelling, you do the bulge or stroke test. Moderate swelling, do the patellar tap. Severe swelling, do cross fluctuation. And as a chronic case, you can look for synovial hypertrophy. Never forget to examine the popliteal fossa and the patella. In the patella, look for facet tenderness and patellar grind test. Coming to movements, it's always important to look for deformities and extensor lag. Extensor lag is common due to bucket-handle tear of meniscus, and terminal flexion pain is usually due to tear in the posterior horn of meniscus, and of course crepitus. Measurements, you should look for quads and calf wasting, and you have to measure the Q angle also in case of patellofemoral instability. Coming to special tests, in ACL these are the three common tests useful. One is the anterior drawer, second Lachman, and the pivot shift. This is the anterior drawer. Keep the hip in 45-degree flexion and knee 90-degree flexion. Make sure there is no hamstring spasm, and then you just do an anterior translation of the tibia and assess the grade. So first thing to do before anterior drawer is make sure there is no posterior sag and there is no hamstring spasm. Sometimes even there is ACL tear, you will not be able to get the translation because of what is known as door-stopper effect, where the posterior horn of meniscus will prevent anterior translation. And you should always assess the endpoint, whether it is firm or soft, and you should grade 1 to 3, and of course compare with the normal side. Coming to the Lachman test, this is done in 15 to 20 degree of flexion. This is the most sensitive and can be done in even acute cases. Here, again in 15 degrees, you just do anterior translation and assess the grade. Pivot shift, this is for rotatory instability. You keep the patient supine and internal rotate the limb and give a valgus thrust and gently flex the limb. Again, you have grading for pivot shift. Coming to PCL, first thing you see is a posterior sag. Always compare with the opposite side. This is also called as a pen test. You just keep a pen on tibial tuberosity. Normally it won't touch the patella. If it touches the patella, it means there is a posterior sag. This is a Godfrey sign, almost similar. Keep the hip and knee 90-degree flexion and you can look for posterior sag. The posterior drawer test, almost similar to anterior drawer. Just do a posterior translation and then you see how much it moves posteriorly. This is the active quadriceps test. Keep the hip in 45-degree flexion and knee 90-degree. And ask the patient to actively contract the quadriceps. You can see the tibia moving forward. This is the valgus stress test for the medial collateral ligament. This is usually done in 0 degree and 30 degree. If it is positive at 0 degree, it means only the medial collateral ligament is injured. Superficial medial collateral ligament is injured. If it is positive at 30 degree, it means only superficial medial collateral ligament is injured. If it is positive at 0 degrees, it means when the POL is injured along with the posteromedial structures. Varus test is similar for the lateral side. If it is positive at 30 degrees, it is only the lateral collateral ligament. If it is positive at 0 degrees, then the posterolateral corner injury should be suspected along with capsular injury. Coming to meniscal injury, typical clinical signs are joint line tenderness, McMurray's and Thessalyi. Thessalyi, you make the patient stand with knee in 15-degree flexion and ask him to do internal external rotation 3 times and look for tenderness in the joint line. McMurray's, for medial meniscus, you externate the limb and give a valgus thrust and look for a palpable click or pain along the joint line. For the lateral meniscus, you just do the opposite. Never miss posterolateral corneal injuries. Always do the dial test and neck rotation recurvator test. And of course, never miss patella also, because sometimes instability can be due to patellar instability. You always do the upper ankle test and also look for J sign. And never miss neurovascular examination and other joint examination. So to conclude, listen carefully, examine thoroughly, and think clinically. technology and investigations can only support clinical judgment but should never replace bedside medicine. Thank you.
Thank you, sir, for that highly insightful and clinically enriching session on the examination and assessment of ACL injuries. It has helped us understand the importance of meticulous knee evaluation in everyday orthopedic practice. I now call upon stage Dr. Adit Kumar, sir, consultant orthopedic and arthroscopic surgeon.
Good morning to all. I'm Dr. Adit Kumar. I'm here to present imaging of the knee joint and its interpretation. It's basically for the PG students. So if a patient comes to you with an injury and with the complaints of pain in the knee joint, instability or buckling complaints and with effusion, you have to take X-ray, and CT scan is of little importance, and the main gold standard is the MRI. So coming to the X-rays, you take the standard AP and lateral views. It gives a main clue of avulsion fractures where you can see the ACL avulsion and the PCL avulsion from the posterior tibial condyle, and also you can see the lateral tibial avulsion fracture, which is called as lateral capsular sign, that is associated with the ACL tear, and the reverse Segon sign, which is the medial tibial avulsion fracture associated with the PCL injury, and the medial femoral condyle avulsion fracture, which is associated with the chronic MCL injury, also called as Pellegrinus stata sign, and the fibular head avulsion fracture, usually associated with the PLC injury, that is high velocity rotatory instability, LCL, biceps and popliteofemoral ligament is involved in this. This sign is called as arcuate sign. And you also need to take a standing scanogram. It helps in assessment of the coronal alignment so that we can plan for the high tibial osteotomy in case of associated root tears. And there are special views, including the stress views, where the valgus stress views suggest the initial opening suggests MCL tear, and if the gap is more than 3.2 at 20 degrees of flexion, it suggests the grade 3 PCL tear, and more than 9 mm suggests that it is a multiligamentous injury. The varus stress test X-rays shows that more than 2.7 mm gapping shows a lateral collateral ligament injury, and more than 4 mm shows that it's associated with posterolateral corner injury, and more than 7.8 mm suggests that it's a multiligamentous injury. So posterior stress test not usually routinely done, but in case of chronic PCL it gives an idea. A line joining the posterior tibial cortex and it touches the Blumensatz's line. The distance between that, if it is less than 8 mm, it suggests that is a partial PCL tear, and 8 to 12 mm that is a complete PCL tear, and if it is more than 12 mm then it is a multiligamentous injury associated with posterolateral complex injury. So CT scan, as I said, it is of limited role, but in case of avulsion fractures, it helps us to assess the displacements and the fragment size, and the MRI is our gold standard. So reading the MRI, there are 3 planes, the sagittal, coronal, axial, and the sequences are T1, T2 and the fat subtraction and gradient views, and mostly all the ligament appears as black. So in case of any injury, you get to see a whitish grayish appearance, high signal intensities. So there are 2 areas where you need to look at. One is the intercondylar notch that gives you ACL and PCL structures, and the medial and lateral compartment which gives you your meniscus and your collateral ligaments. So coming to the coronal view, from anterior to posterior, you get to see the start of medial meniscus, and initially on the femoral condyle you get to see the posterior cruciate ligament and the collaterals, medial and the lateral collateral ligaments, and slowly the ACL. And in the sagittal view, from the lateral to medial, you get to see the lateral meniscus. As you scroll, you will see the lateral meniscus posterior horn, your patella tendon, you can see whether there is a patella alta or vaga, and your ACL, which is a black dot structure along the roof, just parallel to the roof of the femoral condyle, and the posterior and the anterior horns of the meniscus, and your PCL, and then the medial meniscus. So the ACL tear, there are telltale signs of the ACL tear where you can see the buckling of PCL, you can see the lax PCL here, and the whitish grey structure of the ACL, a non-visibility of the ACL is the appearance, and the empty notch sign, as you can see in the coronal view. Next, you scroll down, you get to see all these images. So there is another entity called as ACL mucoid, where there is a fat degeneration giving you a celery stalk appearances, as you can see here. And the PCL tear, well appreciated in the sagittal view, either at the femoral attachment or in the tibial side. So AP diameter of more than 7 mm gives you a clue that there is a PCL tear. And the bone contusion on the anterior proximal tibia also is suggested. So coming to the meniscus, there are various types of meniscal tears: the horizontal, longitudinal, the radial, and the extension leads to bucket handle tear. So horizontal tear usually appears parallel to the tibial plafond, as you can see here, the high density view, and the vertical is as noted here. And the radial tear you can see in more than 2 sections. If you can see in fluid intensity, then it is a suggestive of meniscal tear radial. The bucket handle tear, the classic sign is the double PCL sign. As you can see, the PCL, along with that there is another parallel structure, the double PCL sign. Then there is an absent bow tie sign. The normal bow tie sign is absent here. Then the root tear, you can see the meniscal ghost sign, which is very classically seen the next adjacent slide of the PCL, and the truncation sign, as you can see in the coronal view better, and is usually associated with meniscal extrusion. The ramp lesion is really hard to find out in the MRI, but a close look will give you a linear fluid signal between the posterior horn and the capsule in the posterior capsule. So you can identify the ramp lesion. The discoid meniscus, not to mention the squaring of the femoral condyle, and you can see the width is more than 15 mm. And if you are able to appreciate this in 3 consecutive sections, the meniscal body, then you should suspect discoid meniscus. So coming to collaterals, you look at the lateral structures, you can see the lateral collateral ligament tear, whitish grayish appearance, and in the medial condyle, you can see both in the coronal and the axial sections. So just in other findings like parameniscal cyst, usually associated with meniscal tears, and OCDs can also be made out in MRI. So the take-home message is MRI is gold standard, but there are 6 to 7% false positive rates in case of meniscal tears, as suggested by the literature. So always be backed up with all the instrument during the surgeries, because you might be having surprises in the theatre, just looking at the radiological diagnosis. Thank you.
Thank you, sir, for that highly informative and insightful session on imaging of the knee joint and its interpretation. I now call upon stage Dr. Aravindan Kalamegam, sir, Consultant and Director of Department of Orthopedics, A.G. Padmavati's Hospital Private Limited, Puducherry.
A very good morning. At the outset, I would like to thank the IAS and the POA for giving me this opportunity. My talk is on hamstring graft harvesting and how to do. So, coming to the topic, this has been described in our Campbell textbook since past ancient ages, 90 years, near about a century. So, next 8 minutes we will be dwelling upon the answer, the technique, and what's changing in 2026. So, if you can see, 1934, around 90 years from now, the technique has been described in Campbell textbook. 1939, the semitendinosus was the graft which was described by Massey et al. And 50 years later, 1986, quadruple ST and semitendinous and gracilis tendon was described in the American Journal of Sports Medicine. And since 1990s, endopatent era has started. Now, 2006, past 20 years, past 2 decades, all inside technique has been described. So, what are all the graphs available in ACL reconstruction? One is autograft, that is the high success rate, low rejection risk is the positive point, and negative is longer recovery time due to tissue harvesting and the donor site morbidity. In the allograft, less invasive and faster recovery, but there is a small risk of disease transmission and slower integration and availability issues. In India, I think still now it has not been resolved. And synthetic graft, it is immediately available and no donor site morbidity is seen, but higher failure rates. Sometimes there is a potential for allergic reaction and thereby inflammation. So why hamstring? In the 2026 evidence is almost return to sport is 80%. And what is the native ACL tensile strength? It is only 2000, whereas the hamstring tendon is 4000 Newton. So till now, it's the number one most commonly used ACL autograft, almost globally in almost all peer-reviewed journals. So know before you cut. Anatomy comes first, always. Understand, it's a persistent tenderness is the like the foot of the bird. So 4 strands. The insertion landmark, what you should remember is, number 1 point is 4 to 5 cm distal to the medial joint line and 2 cm medial to the tibial tubercle. And the layer anatomy is semitendinous, lies deeper and more distal compared to the gracilis. And commonly encountered critical structure is the infrapatellar branch of the saphenous nerve, and it crosses obliquely, and it is the number 1 to be protected in these surgeries. So why semitendinous or gracilis alone? Predictably, the length is more, 25 to 30 centimeters, and predictably the diameter also is slightly thicker compared to the gracilis. And when you quadruple, you get to get the diameter of 8 to 9 millimeters, whereas in gracilis, predictably you cannot get it. So the modern direction is 6 to 8 times semitendinous alone is achieves the 8 to 9 diameter with very minimal, less than 5% of failure rate in ACL reconstruction surgeries compared to the combined semitendinous and gracilis tendon. So how to harvest? So it is better to mark the bony landmarks and the tendons before cleaning and draping, so that the marker does not get disappeared by the process of cleaning and draping. So keep the knee in 90-degree flexion, hip flexed and external rotated, and figure of 4 position, and mark the 3 landmarks, patella, patellar tendon, and the joint line with skin marker. So what are the incisions? 3 approaches. Commonly used is the lowest nerve range, which is the oblique approach. Slightly longer curve, learning curve, because usually we will find it difficult to delineate the sartorius and the semitendinous, gracilis and the semitendinous tendon. Whereas the vertical is direct access, but there is a high risk of infrapatellar branch of the saphenous nerve is encountered. The posterior approach is very short scar, but the risk of injury to the common coronal nerve is very high. So, identifying the tendons, hook the semitendinous first is the price, and gracilis is your insurance, is not your goal. So, distal release and access, open the sartorius fascia in line with the fibers. First, do the whip stitch before releasing the tendon, not after releasing the tendon, and release all the facial bands medial to medial gastrocnemius. No expansion can be sized by the probe at the inferior tendon, and stripper inserts easily along the first 10 cm. If you encounter any resistance, first stop, reassess, then go ahead. So the tendon stripper, wherever the good nerves are won or lost, the constant tension parallel to the tendon post, and the knee is flexed 90 degree and hip is flexed, advance slowly in line with the tendon, no rotation or no leveling. Whenever resistance is encountered, stop, reassess, then go ahead. Beware the iatrogenic silvian injuries whenever the stripper is aimed medially or to posterior, it can injure the common coronal nerve. So, back table preparation, strip the muscle, measure the length, fold either 4 strand, 5 strand, 6 strand or 8 strand, size through the block, then whip stitch the ends. 6 time usually will achieve 8 to 9. 8 time usually will achieve 9 to 10 mm. So whenever you achieve this 8 or above 8 mm tendon reconstruction diameter, your failure rate is very low, less than 5%. So ideal graft length, the graft length usually in the femoral and the tibial tunnel 2 cm is adequate, and intra-articular portion is 3 cm is adequate. So the total is 7 cm quarter to consent is more than sufficient. If you achieve that and the diameter is 7 to 9 mm, the success rate is very high. In the quintupled, this diameter of the tendon is tendon auto construct is more than 8 mm. You can easily spare the gracilis tendon. And in octupled semitendon is only all inside technique. The success, even if it is a short graft, 60 to 70 mm, and diameter is more than 9 mm, the success rate is very high. So closure, try to repair the sartorius fascia and prevent the post-operative snapping sensation in the patients, and subcuticular skin closure. Compression dressing, no drain is necessary in routine cases. So what are the complications when we see in hamstring autograft harvesting? First foremost is more than 1/3 the saphenous neuroplasticity is encountered, and premature graft amputation. It's a top cause of failure of the reconstruction, and majority of the cases, almost 4/5, you see hamstring weakness, but usually the hamstring weakness is a transient phenomena. At end of 1 or 2 years, almost 80% of them recover fully, and post-operative hematoma and common coronary injury is usually encountered in posterior approach, very rare. So salvage pathways, if you are encountering an inadequate hamstring graft and the diameter is less than 8 mm, usually augmented with hybrid allograft, or length is shorter, you continue with ST alone. And if there is a catastrophic loss, switch to bone tendon bone or quadriceps graft. Pulse and fit pulse. Mark the pressure before tourniquet inflation. If the stripper face tight, or if it is tight, withdraw. Whip stitch before you strip. And saphenous nerve heads vertical excisions. Gracilis is insurance, not the goal. Retention on the back table, not in the tunnel. So recent advances, there are quadruple graft link technique with the tightrope buttons, suture tape augmentation with artificial synthetic materials, and ligament augmentation reconstruction techniques, and pre-op size prediction, the MRI cross-sectional area predict diameter. So graft choice in 2026 is return to sports rate is 80% till now in 2026, with hamstrings 80%. Bone tendon bone is very high, quadriceps very high, peroneus is comparable, and donor mobility is moderate, whereas in bone tendon bone anterior knee pain is there, and quadriceps is variable, and peroneus longest, distal most it's lower and it's localized. The strength profile is favors extension. In bone tendon bone, the variable in favors flexion. So till now, this thing is the next 5 years, tissue engineered scaffolds are going to come in a large way, and patients with MRI driven derived dimensions guide preoperative planning, and hamstrings is going to go away. So take home message: master the anatomy, respect the tendon, achieve 8 mm dia, and the graft will definitely help you. Thank you.
Thank you, sir, for an excellent and practically oriented session on hamstring graft harvesting. Your step-by-step explanation and surgical insights have given us a much clearer understanding of the technique and its importance in ACL reconstruction. As we are now ready for the live surgery that is being performed by Dr. S.R. Sundarajan, sir, moderator Dr. Sasinder Mugasundaram, sir. Today we have an opportunity to observe his approach of ACL reconstruction, including surgical planning, technique, decision making, and intraoperative pearls. This session will be an excellent learning experience for all of us.
Good morning, sir. Sir, are you able to hear us? Sundar sir, good morning. I'm Dr. Sasinder here. You are not audible to us. So if someone can help us with the audio. Yes sir, yes sir. Clear. Sir.
Sasi, okay. So this is the patient of 40 years old, male patient, had a fall from a two-wheeler 2 weeks before and had this knee injury, and the patient had got only ACL tear as per the MRI, and I had gone through the MRI scan also. And this is what we have now. We have done just almost 5 minutes before this case. I did a diagnostic round. And can you focus here, outside view? If you are starting for an ACL reconstruction, this will be an ideal case to start because it's an only ACL reconstruction, no meniscus, no collaterals. But always when you have an ACL injury, you expect all those things to happen like a ramp, meniscus and collaterals. So these are sports injuries, so that's why you are not seeing all these big associated injuries. Can you see the outside view now?
Yes sir, clear.
That's the outside view. Yeah, so I do in the same like leg support with like a T-car position with one support for the foot. Some of them can use even the with the legs hanging down. So I was doing 20 years before like that. Then I changed to the this position. So because the position is easier and it is quick. So you have the thigh support and you have the foot support here. And this is always as a beginner to be able to make a mark so that you know where you have to mark. And I made a lateral portal. The lateral portal usually I make as close to the, can I zoom it up so? We make as close to the patella tendon and little height. And when you go to the medial side, you can see there's almost 1 centimeter from the medial bar of the patella. So that you can have that your assets for your entry point and the femur will be oblique. So if you go above, then it will become very low in the entry point. If you come very low, then it will become a more vertical tunnel. So you can adjust it, but suppose you want to do a revision, sometimes you actually adjust your entry point. So generally, you always you can use a 2-portal technique or a 3-portal technique. So generally I use 2-portal techniques like this. If you want to do a 3rd portal technique where you can use a one more anteromedial, high anteromedial technique, portal, where you can view through the high anteromedial and work through the low anterolateral, far lateral portal for your femoral entry point. If you want to perfectly see your lateral right. But most of the time, if you make a portal close to the patella tendon on the lateral side, you will be able to see the notch very well. So you don't need to make a 3-portal. So usually I make a 2-portal. Now we go for the graft harvesting. We have 23 blade. So because now a sports person, I'm planning to do a hamstring graft, 23 blade. So this is the mark which you made. You can see that there is a tibial condyle here. So the tibial condyle you make it maybe a medial and 1 centimeter distal. So you should stop the incision like this. You can make it vertical or an oblique incision. But the oblique incision has got a less chance of nerve injury as per all the studies. But even if you make an oblique, you can have a nerve injury. There is no doubt about it. But the oblique incision maybe instead of 40% if you make an vertical incision, maybe oblique will go to 20 to 30%. Can I give you one more retracted. So you can see that there are a little oblique incision, forceps and lemon blade. Can you see the inside here? Can you zoom and show here?
It's clear, sir. You can
Clear?
see.
Okay, that's okay. Forceps. Because this patient has got only, so for the demonstration purpose, probably I will make a small incision, I will make a little bigger incision. Okay? So that we can see it better. So the main way of taking the handshake grab, whether you can take from outside in or you can take from inside out. Usually I take from inside out, so it makes it very easy for you. So you can see there is a pistance area, and we make a cut, divide the pistance area from the tibia, so that we can switch it back. So it is not that we cannot switch it back, we can switch it back with monoplate. Go up bit, yeah, thank you. So what you see underneath is the MCL. Can you see that MCL?
Yes, sir. Clear.
Yeah. So that is the superficial MCL. What you have seen the pistance area here. So this is makes so easy and it's quick also. Can I give a artery, straight artery? Straight artery. And I want to show from like this so that you can see the inside of your pistance area. Can you see here now? Hold it. You don't do too much. Just hold it like this. So I'm having the pistance area. Can you see the inside? Can I show the inside? Forceps. Safi?
Yes, sir. Clear.
Any?
Only
Okay.
focus looking at this direction.
Yeah, can you zoom and show it here, this one? Yeah, can you zoom and show? Can you see the tendons here?
Yes, sir. You have both the restless and the semi-T in your hand.
Yeah, no, okay, see. So what you see down is the semi-T, what you see above is the gracilis. So usually the semi-T runs downwards too much here, and gracilis will be more horizontal type of direction. Use the right angle please. Use the right angle to take the semi-T first, as you see here, long blade. Then take away from the your pistons area and go up to the bone so you can have the enough length. Straight artery. Now you can release the vinculae because semi-T has got at least 3 vinculae, so it has to be released, otherwise you can have a good vision. So make sure that you have a hold of this. I don't know whether you can see the vinculae, which are able to see the scissor, curved scissor. Have a attached scissor.
Do you take bites in the stump before releasing the vinculae, or you're okay with this?
Yeah, you can take, yeah, okay. Yeah, usually I don't take, but today I will take it. Stitch number 2 by the way. So better, I mean, yeah, as if you are a beginner, so if you are doing a few cases, better to use the stitches so that you can have a hold on it, because if it goes inside, then it's difficult to find for you. But I don't use it regularly for the stitch purpose. For the demonstration purpose, definitely this, yes. I would recommend to do the stitching so that you don't lose your tendon. That is also very important. Okay, curved scissor. So when you use a curved scissor, use it pointing downwards, not pointing upwards, so that you don't cut the tendon. Okay, so you go along the tendon, cut below the tendon, slide it. Then you know that you have released the semi-T very well.
Any trick in identifying the vinculae and not confusing the vinculae as a tendon for younger people?
Forceps. Always it's a big forceps problem. Make it faster. So you can see this is the vinculae. So the vinculae.
Hello, sir.
Yeah.
Sir,
Yes,
we lost you for a while because of some
it's okay.
Yeah.
Yeah. No problem. So I think I showed already someone to take the semi-TV.
Okay, sir.
We can go through the arthroscopic view now.
Sure, sure.
They can show the arthroscopic view. Can you see the video or not yet?
We're just trying to arrange that. The bigger screen is lost. We are trying to arrange the TV.
Oh, okay. Big screen I have a picture. It's a net issue or no? It's not a net issue.
It's not an internet issue. It's a power issue.
Oh, okay, okay.
You please proceed, sir. I think a couple of minutes we should be back.
If I proceed, I will finish it in 10 minutes. It's only ACL.
Yes,
That's
sir.
right. So we take it.
10 minutes.
It's only ACL, no, there is no, but it's already did a diagnostic round. There is nothing much to show. So meantime we are preparing the graft, it's okay. We'll prepare the graft, then once you come for live, I will finish in 10 minutes or 15 minutes. Tadi ya bulan, plus minus ciuman. Soundboard. Maybe still I don't know, unless there is a restriction, any weak or ACL with restriction or extension, flexion needs surgery. Most of the patients got a full range of movements will do conservatively very well. Just to give a quadriceps exercises, get back the movements, they will do very well. Unless they have a restriction of 10 or 30 degrees, 40 degrees, and no improvement after conservative management, then we do decompression. My numbers are very, very less.
So we are just still waiting for the screen power to come back. So just few simple questions for the youngster.
Yeah, okay, we will look at the probably, yeah.
Yes, sir.
Any questions?
How do you decide whether you want to do a lateral procedure like a lateral extraarticular tenodesis or ALL reconstruction for these patients who come to us for anti-instability?
So you're asking me?
How do you decide whether a patient requires a lateral anterolateral procedure?
Usually the money choice of patient is the same of literature evidence, whatever it says. Like athletic patients who got a glass pivot shape, highly obesity patients, the patient has got a hyperlaxity. So that patients you can have some extra protection by giving the anterolateral reconstruction. And all the revision procedures, usually when I do all the revision procedures, usually I include the LAT. If there is the slope is normal, if there is a problem of only instability with the ACL rupture, then you do the ACL with the LAT. Otherwise, generally we do only ACL reconstruction. And the graft choice also, as I said, this patient is a non-sport person, that's why we use the hamstring. We know the hamstring has got a more re-rupture rate than the PTP or quadriceps in a sport persons. So in athletic patients, I do PTP graft. Some patients I do quadriceps. Otherwise, most of the patients who are less active, recreational players, hamstring is more than enough. So LET, most number of LET is what we do for mostly hyperlaxity patients and obesity and gross pivotship. And of course, all the revision ACL usually include the LET.
So we are live again, sir.
Okay. So you can see the arthroscopic view.
Yes, sir.
So already in the lateral picture, as you see here, this patient is there is a trochlea, looks good. Rotate your right source to see the upper surface of the patella, that is the lateral facet, and that is the medial facet. That looks good. Then go to the lateral getter and you can go up to the popliteal fossa to see that is the popliteus tendon, that is the popliteus fossa. Okay? That is the diagnostic ground that normally you do. Sometimes you can suspecting some loose bodies or you are searching for loose body. This diagnostic ground always helps you to find out everything so that you don't miss any of the compartment. Then you go to the medial compartment. You see the periphery of the medial meniscus of the body and the anterior. Then you usually come to the knee joint. Now flex the knee joint to the 90 degrees. Now you see the knock too, so you can start working on that. You should do the figure of 4. Already done the diagnostic route, but still I would like to show that lateral meniscus is normal. Already I poked it, everything is good. Go to the medial side, so you can see the position of the lateral meniscus opening the outside. You have a figure of 4 position. And Arun Prasad is doing the internal rotation of the foot so that will open up the joint.
Sorry, sir, is it possible to show the outside view also? We can't see the outside view. We see only the outside.
Yes, can you show the outside view? Outside view. Yeah. So you can see that there is a figure of 4 position. And this foot is held in internal rotation. And our assistant is pushing the knee down. You can see by pushing the knee down, that will open up the lateral joint space. And also if it depends upon the different type of flexion in the same position, you can see the different kind of opening. So you see on all these maneuvers so that you can work out for your lateral joint opening. Come to the medial side. So lateral side is normal, already done everything opening. Now we do the medial side. To the medial side, you do the flexion of around 30 degrees and do the external rotation of the foot. Here I am using the side support as my support so that you can use it as a post and you can use the valgus post to open up the medial side. So you open up the medial side. Yeah, sorry. Sorry, what that is, what it's not about. Okay. Pro, please. So the joint is good, the femoral canal is good. Can you give me the pro? And always it is very important that even the MRI shows normal. You try, go and palpate yourself the whole meniscus so that you don't miss the tear. Sometimes the MRI quality is not same for all the cases. And if you want to open up the medial side, especially the posterior arm, the same position, you try to do the extension like this. You can see that how much it is opening on the medial side. You don't need to do a pike resting for all the cases. So if you have this much opening, you don't need a pike resting. Pike resting will do the same job. So unnecessarily we should not do a pike resting. The maneuvers are very, very important. It shows the outside view. Outside view. So you can see that I'm doing an external rotation, using the side support as my support and giving a pressure on the valgus opening, and you can see how much it is opening. When you do the posterior arm, it is almost an extension. When you go to the middle third, they are opening, then you can give a 30 degrees flexion that will open up the middle one of the middle meniscus. Okay?
Yes, sir.
Yeah. Now we will go and prepare the notch. Generally, usually I try to take away some fat pads so that you can see the joint very well. And here I am using the aggressive shaver to remove my remaining stump of the ACL. And you don't need to keep all the fat pads, so you'll be struggling. So what is important is that your visualization is the key when you do an ACL reconstruction. This ACL is not a very healthy ACL. They are almost like a little bit mucoid because he is a 40 years old, not a sports person. And you can see that the ACL quality of the ACL is not great. And you can see the notch is very narrow, so all the notches are not same. As you see here, this notch is a narrow and it's a tall notch. So each notch for each person is totally different. You have a short notch, you have a wide notch, you have a severe, and this kind of very high, having a high notch. So here, this space is very narrow, so I'm going to do a slight notchplasty, nothing wrong in that. Usually I don't do routinely as a notchplasty. And this will give you a good visualization also, and it will prevent your lateral impingement for these kind of cases. And we are already preparing the graft. We had the 6 strands hamstring graft, and it came around 7.2 length, and thickness is around 9.5. Oh, good, very good. So we have a 9.5 of the thickness. And you can see the entire footprint of your ACL. Pro, please. So all the cases, especially if it is not very chronic, most even the femoral side, and you will be able to see the footprint. So the footprint, you can see this all this footprint. So this is the anteromedial bundle up to here, and this is the posterolateral bundle.
Sir, if you are not able to see the footprint, how do you
I'll do it again. Yeah, 1 minute. I will make a little bit, do you have small blood also? But in the blood. So you can make a little notch plastic so that you can see it better also. So most of the time even the aggressive shaver itself will do the job. You don't need to use them, right? The remaining fibers, huh? Yeah. Okay. Can I give the probe now again? Can I see the inside view better?
Yes, sir. Beautiful.
So this is the anterior part of the notch. Always feel the posterior part of the notch before you start your case, because this visualization is very important so that you don't do any mistake of entry point. We know that the most common mistake happens in ACL failure is because of the non-anatomical placement in the femoral side. So make sure that your entry point in the femur is okay or correct. That means your surgery is okay. You are successful. Otherwise, the chance of failure is very high. So you can see these still fibers or remaining fibers. I have not entirely denuded all the cartilage. All the fibers are collagen, so that you can see the footprint. This is the highest point of your footprint, and this is the anterior-most part of your footprint. Up to here, you can see this, and you can see this is the lowermost margin here. So this is such a big footprint. So we are not going to recreate everything here. That's what the ACL is, which previously we used to do a double bundle ACL reconstruction, because we do an acromedial and the posterolateral. Now we try to recreate most of anteromedial bundle rather than posterior lateral bundle, because the problem is, when we started doing anatomical entry point, that means we started coming too low here. So when you come too low and anterior, the chance of failure is very high. When you go more proximal, then the chance of failure is very high. That means you are reconstructing more of, this is the more of anteromedial bundle here. This is the posterolateral bundle, the what you see in the front. Okay? So, you have diathermy also. So if you want to, yeah. So, in many ways you can make the footprint, as I said, that now, if I have this kind of entire footprint, we don't need to worry. You can use the probe, you can use the measurement, and all those things. But I always use the guide by 5 mm and 7 mm offset. Offset guide, please. The offset, 6 mm offset. So, flexion. Yeah. So you can see, this will help you to have the strong hold of your entry point, so that you don't miss you will not oscillate in the hand. So always I use the guide, so that is the arm. Suppose if you think that is graft is big, 10 mm, 11 mm, then don't go entire way to posterior, then you will break the posterior notch. Then try to adjust your jig. Instead of like this, you can keep it like this. You can tilt this way, you can tilt this way. So many ways you can do this. So the notch is, the guide is not the ultimate for you to decide your entry point. Still you adjust all your hand, make sure that you are entering in the correct entry point. So you can see the entire footprints. I'm not going too low like this. I'm not going too vertical like this. So this is the ideal entry point for you. And we have almost around 120 degrees bend. The outside view, can you show the outside view? Almost everywhere. Here I am using the 3-point layer. So we are making the entry point now. Yeah. Go. Get up, go. Oh, don't stop, man. Check it, please.
Where do you aim to exit, sir?
Sorry?
Where do you aim to exit the wire?
So the aim should be at least should be in the middle of the thigh or slightly higher, not too low. If you go, yes, where do you put it on? Okay. You can increase the probe. So if you want to check it again, please check it probe before you put your reamer. Still you can check it. So still you have a chance to check how much posterior bone left for your entry point. And you can see that is the probe again. So you can recheck it again. So that is your lowermost portion of your footprint. Okay, that is your highest entry point. So I go more of anteromedial bundle than the posterolateral bundle. So this is the 4.5 reamer for the button to go and sit there. We are planning to use the adjustable loop. So this is very high now. So normally you don't get that much oblique view, but you can, because okay, straight here and the reamer. Over again. Reamer. So the length is around 40 mm. So it is important when you use an adjustable loop, there are two markings which you are you are going to mark it. One is the length of the tunnel, one is the length of the graph which you want to put it in the femoral side. So this is the 40 mm mark. So we have around mark it. We have a small 4 mm canvas. 4 mm canvas. So. Hold this. The minimum graph has to be in the femoral side is around even 15 is okay. Okay. So you can see this is a nice trick where you can use I'm using the 4 mm cannulated reamer here in my hand, so that when you have all the debride, when you have a deep fluxion like 120 degrees, your visualization is hampered. So hold this, so that you can see your entry mark is, you can see it better now, okay?
Yes, sir.
These are all the tricks which you can use it. So it will drop another. Right, okay. So I want to see so this is around 15. I want to go around 17 to 18. Okay, it's got almost around 19. Next point. So still you can restrict your graph when you put it. If you mark it 17, you can still keep it in 17. You can come back and fix the tibial side, take it, you can tighten the femoral side, so that you don't need to worry about the length. Even if you go 3 or 4 mm more than what you wanted, it doesn't matter. And especially the adjustable loop. So Pro, please. Can I see the 19 degrees? Yeah. Can I see the entry point now?
Yes, sir.
Pro. So see. So as I said that this will get water, we kept the remaining footprint. You can see the remaining footprint which we have the original ACL and exactly where we wanted to recreate our tunnel. So this is the almost post-lateral tunnel we don't want here, so more of here. So almost is 80% of your original footprint is covered in this. If you want to reassure and see that you are okay, you can come through your medial portal. So now I am seeing through the medial portal to show the tunnel just for the demonstration purpose. Okay. Now we will go to the tibial side. Right, so tibial side we do it in the 90 degrees. The femoral side we do it in 120 degrees or 130 degrees. We need a deflection to create the tunnel and remove all the debris. That is very important because even after the reconstructing the ACL, I would recommend to remove all the debris with the suction because they can create a lot of efficient post-operatively. So it is very important to recreate. So you can see the tibial footprint already you are seeing it very well. The entry point is going to be corresponding to your anterior horn of the lateral meniscus, that is the anterior horn of the lateral meniscus, and that is the entire footprint of your ACL. I don't want to come too anterior, at the same time not too posterior. So you can try to come here so that you can get in the center of your footprint. So you can use many aimer for this, whether you can have a tip aimer, elbow aimer. This is a flat aimer, this is called footprint aimer, where you can see the mark here. So your entry is going to be just in front of that mark. So you can plan according to that. Go ahead. Any questions also, I'm ready to answer. Otherwise, meantime, I'll keep talking.
So suppose you're not able to see the footprint, meaning there is no stump attached there. Are there any tests that you would like to suggest?
On the femoral side?
On the tibial side, sir. There is absolutely no stump in a chronic case. So how do we identify the landmark?
To be frank, the tibial side I never seen without footprint. So even if you see after 5 years, you will have a footprint. The femoral side, yes. The femoral side always you will have a problem. Put a 7 test. Put a 7 test. So the femoral side you can have a problem. Then these jigs will help. You can have in some cases you can measure it and do it, where you can measure the whole notch, keep 40% from the posterior side, make an entry point. But in the tibial side, always you have a footprint. You can see that even the chronic ACL, you can see, you'll be able to see nicely footprint. This is hard. So here, what I'm trying to do is serial remake. Because the graph is little 9.5, so I don't want to put a 9 directly because it is a more metaphysical bone. The possibility that you can break the anterior cortex if you are not careful, you are using a bigger size like 10 or 9. So always try to go serial remake like this so that you are safe later. And you can put a 9.5 now.
What is the upper limit of thickness of the graft that you will accept, sir?
Upper limit is fine. Lower limit we want to put 8 or 8. But in some cases where now small build patient or a small female patients, I would accept even 7.5. So there you cannot go and aim for a 9. You don't need to do the artery position. Artery. Yes, thanks. So here, yeah. So I would request Arun to hold it like this so that he can hold it in the center. Again, so even to make an entry point now little long, you can take it on the lateral side, you can take it on the medial side, you can go on to the posterior side, you can come to the anterior side. So you can take extra 2 to 3 mm reamer when you do a further remake. So still you can do a lot of adjustment. Okay? Hold it like this. Don't bring it anterior, keep it like this. Huh? So posterior is little fine. Don't try to bring too anterior because if you break the cortex, then it is not possible for you to put an interference screw. Then you have to go for other options like a post and extra lateral anchors. Yeah. Lateral anchors and all those things. So here you don't aim for any joint preservation surgeries because this is not a sports person or a good quality ACL. This is for suction for therapies. And here we don't need to worry about how much footprint you want to keep. I try to keep remnant preservation in young patients who are not sports person, where you can try to do that. But here not. Can you give the nibbler? So you make entry point very clear so that you don't struggle with the graft passage. So sometimes if you are not clearing your entry point properly, the tibial sides and the graft may not go very well. Okay, retract retract on the both the sides, please.
Can you please
I need a lot of
outside view, sir?
Yeah, I'm trying to. Can you see here?
Too bright.
Usually I use the ring. You can see the.
Yes, sir. You are clearing the soft tissue in the aperture area.
Yeah, aperture area. So that when you go for a graft, that should not obstruct that. That is the.
Sometimes if you don't clear the aperture soft tissue, you will be trying to pull and bothering what exactly is going on.
Because that fascia is very strong. So if you don't clear the entire circumference of your entry point, apex point, sometimes you will be struggling there. Can you use the straight gauge wire and the guide wire for the graft shuttling, please? Okay. Flexion. So I'm going to use the shuttling wire. Better. Can you give me a pad? Yes. Careful. Yes. Take out the.
So one question regarding choosing your reamer size. How do you match your graft size and reamer size? The graft should be very tight. For example, if I say it is 8 mm graft, it should be very tight in the 8 mm tunnel, or it should be easily going through the 8 mm tunnel.
So I want to have a exactly fitting graft, so hold this. So normally I suppose if it is an 8, I usually take the 8 size reamer. What happens sometimes even if we do all this penny market close grasper. So normally I use the same size graft surgery, but still if you are not measuring it yourself, what happens, your assistant will measure before making preparation. They will roughly measure, they will tell the size. After preparation, the size will change 5 mm, 0.5 mm or 1 mm of the state. Then you will get sometimes you do script grafts, sometimes you will get yes, enough. So you can see that this is the outside view. Can you see that? So this is the adjustable loop. Can you see so?
Yeah.
Outside view and see the graph here.
Yeah. That is the graph.
Okay. So you can see this.
Yes.
7.
Okay.
So that's why I kept the femoral side. I want to mark around 80, something to 80. So you have 2.5 the femoral side. Tibial side you have. I know that you have some short of length of the graph because even if it is a little short, I don't mind. I use a screw. I add additional post. So this is the length very important for your adjustable loop. This is the 40 mm which is already pointed out. Can you see the mark here?
Yes.
So this is the mark which goes up to the entry point, and this is the graph which you want to go inside. Okay, so even if you read a little bit more, like if you have 17 mm graph you mark here, when you read you went to 20, doesn't matter, you stop with the 50, 70, then you fix your tibial screw, again you tighten it, so it doesn't matter. Go ahead. Okay, we will pass the graph now. Go here. Yes. Go ahead. Yes. So there is the button which is going inside now. So sometimes the button can go horizontally and block it. So you can see which is the blue thread is the leading stitch. So take the blue thread as a leading stitch. Then take along other threads. So you can see that the white tape, small tape. So that is the one which is going to hold the graft, holding the graft. So finally, when you pull the graft, you pull the white. But when you take the button, you take everything together. Okay?
Yes.
Okay, go ahead. Go. So we want to go up to 40? Yes. Come on. Yes. You can see the mark now. The mark is at the entry point. That means we are perfect. Your graph is already flipped there. And I'm trying to pull the graph. You can see that the leg is moving, the graph is not moving. That means your button is perfect. It didn't cross the tensor fascial area or skin. So make sure if you are a beginner, sometimes the assistant pulls very vigorously, the button can come out of the skin or come out of the tensor fascial area. How do you find it? One is that you see the mark here, that means your mark is an entry point. That means your length of the tunnel is fine. You are measured 40, you marked here 40, so you are perfect. Then you pull it and see any bungee effect. Sometimes when you have a tensor fascial area, it's split through the tensor fascial area. When you pull it, it will move 3 to 4 more. It will go up and down. It's like a bungee. It's called bungee effect. But you see here, it is very firm. It's not going at all. That means you are confident that it is over the bone. You don't need to use the Siam. If you have a doubt, still you can use the Siam. Not the problem. Now you can see that the white tape which is holding the graph. Our Arun is going to pull these graphs.
Can you please show the outside view, sir?
Outside view?
The white tape, yeah.
Yeah, we can see the white tape.
Yes, sir. Yes, sir. Can.
This second generation tightrope, okay, pull it. So pull alternatively, gently, and yeah, go. Yes, enough. Yeah, perfect. Now, what I try to do sometimes, I hold the graph very firmly. I tell Arun to tighten it a little bit more. I don't allow the graph to go up, but it will tighten the knot in the. It's a one-way mechanism, Chinese knot mechanism, so it will get tightened up there. Okay? So already I tightened enough. You can see that I'm pulling it back. It's not coming down. So that means it's good. You can see that a nice entry point. Do the extension. Nice extension, full extension. Okay, there is the almost here a hyper extension, flexion. So this way, I mean, you are not going to do any notching here because your graph is not too vertical like what we do the transtable technique. So this is almost a perfect ACL graft. So we go and fix on the tibial side with an interference screw. We do it at the 20 degrees of flexion. Yeah. Retractor please. Here is some proper which we use for the graft. Can I show here? Retract the outside view in the ramming, Let the unity support me. What the program? Can you see the outside view, Shazi?
Yes, sir. Can see what it
No,
is.
no, use too much.
Can you reduce the brightness, sir? Yes, sir. In the graph,
You see it?
yes, sir. Yes, sir. The graph is just visible, right?
Yeah?
Yeah. Can
Yeah. So you see that the graph length was only 7. Okay? The way I adjusted so that I know that I can have the graph at the entry point. So I didn't put too much graph inside. I kept only 18 mm inside the femoral tunnel, so that I know that I don't need to worry about too much about the shortness of short of the graph. Okay. So usually I assist with some spine awl which you use for the vertebral fixations. I try to see how much gap between the graph and the bone, whether I can insinuate my awl inside or not. If I can insinuate, that means the graph is measured not perfectly, some looseness is there. Okay? This is a 9.5 size graph, so I'm not going for a 10 or 11 because it's already snugly fixed graph. Better to use the 10 size screw. I'm going to use a 9 into 30. 9 into 30. So when the graph is loose, what happens? You can use one size more. You suppose the graph size increases to 9, 10, 11, don't use one size more. That means your screw size is also going to become more. It's very difficult to go enter. It's not possible for you to enter the center space between your graph and the bone. So even one size smaller, sometimes it doesn't matter. If you are using a 10 size graph, suppose it's snugly fitted. I use one 9 size screw. I don't use for 10. So you don't need to struggle with that. So here we are using the 9 and 30.
You want to put the guide wire anteriorly or posteriorly to the cursor?
So see whether it is going freely, I put it. Usually it go posterior to that, so that when I go more and more distant, your bone is become more stronger. You know, you're more proximal, the bone is more metaphysical. When you go more distal, the bone is more stronger. So try to go as distal as the distal as you can. Mostly I go distal. Smooth shaver again.
What's the position of the knee?
See, tighten it again.
What's the position of the knee?
Now it is 90. Already I done the fixation, I come to the 90 degrees. You can see that again, we are doing one more tightening of the graph. Smooth shaver. Smooth shaver. It's okay. Yeah? It's good. Lina, good. Capital. Share பண்ணதுவா இதுல ஷேர் போடுறீங்களா Okay, pro please. It's okay. Almost over. That's okay. Pro. Straight. Sati. Hello.
Yes, sir.
Okay, so you can see that's a nicely fixed graph here.
It's a beautiful
Extension. Okay, that's it. Flexion. Okay, I think that's it from my side. Any questions I'm ready to answer, or I will come there. Any questions? Also, I want to thank anesthesiologist Arun Shantamurthy for coordinating this program and all the Arthrex company guys and all the staff, audio visual guys.
Sir, there's a question. The Ekman sir wants to know what is the question on the knee when you start putting the interference screw?
We had done around 20 degrees of flexion, 10 to 20 degrees of flexion.
Yes. Any questions from the audience?
Okay, if there is no questions, you will come there and.
Yes, sir. Thank you very much. It was beautiful.
Thank you, sir. Thank you, everyone. Thank you, Ramadi.
Thank you, sir, for that wonderful session.
Thank you.
I now call upon stage Dr. Sashilus Shanmugam sir to enlighten us about the bone patellar tendon bone graft harvesting.
Good day, everyone. First of all, thank you to the organizing team, Dr. Manikandan, Dr. Vijayaraghavan, Dr. Gopi Shankar, Dr. Aravindan, and everyone for this wonderful opportunity to catch up with all my colleagues in Puducherry. And thank you for this opportunity to talk on bone patellar tendon bone graft harvest. I am Dr. Sasinder, consultant arthroscopic surgeon at SRM Global Hospitals and CAT Sports Injury Center, Chennai. A very well Pondicherry payan. Okay, so there have been a lot of quest for the ideal graft since time immemorial, and the ideal graft is supposed to be biomechanically similar to the native ligament and easily harvested without any donor site morbidity and get very well incorporated with the bone. And that's also the reason we never got to reach that ideality. But the patellar tendon bone graft appears to be the most ideal graft or most predictable graft so far. There are certain indications. We started with patellar tendon bone graft way back when we started ACL reconstruction, but it has shifted towards hamstring grafts since we had a lot of innovations and we got the arthroscopy equipment, and we wanted to make the graft harvest easier, unlike previously when we did mini open ACL reconstruction. We used to do the patellar tendon bone graft harvest and use the mini open approach for the ACL reconstruction. But nowadays we don't do mini open, we do arthroscopic, so we want to use a simple incision or a simple procedure for graft harvest, and that is why we shifted towards hamstring graft. But still, there are certain indications where bone patella tendon bone grafts fare far better than hamstring grafts or other soft tissue grafts. Some of the indications in my practice are sports people, athletes, contact sports, obese patients, or revision ACL reconstruction. So this is an example of a failed ACL reconstruction. That means the patient has come for revision ACL reconstruction with frank grade 3 Lachman and grade 3 anterior drawer, and that is the past surgical incision that you are seeing there, previous hamstring graft harvest. So this patient is a very good patient for bone patella tendon bone graft. But what are the complications? What are the issues? There can be anterior knee pain, but mind it, there are certain other causes for anterior knee pain that includes patellofemoral pain because of poor rehabilitation after surgery. So all anterior knee pain that are coming after bone patella tendon bone graft harvest is not because of the graft harvest. It is also because possible improper or inadequate rehabilitation of the patient. And there is the risk of patella fracture if it is not done properly. Patient positioning, patient is positioned in the supine position, knee is bent to 90 degree and you alternate to extension and flexion as required. Patient is on a 20K in order to prevent bleeding and also to improve your visualization. You can use a leg holder. A lateral thigh support is definitely required. That's the kind of position that I require. The incision is usually not so big, but for demonstration's sake, the incision is slightly bigger in this particular patient. There is a longitudinal incision slightly on the medial side, not in the midline, because the slightly medial incision can also be used for placing your tibial screw. So that's a longitudinal incision slightly on the medial side. You expose the patella tendon completely, and then you have to incise the paratenon and separate the paratenon. Don't harvest along with the paratenon. We want to close the paratenon after harvesting the graft because we don't want adhesion between the skin and subcutaneous tissue and the patella tendon. Measure the patella tendon mediolaterally. Usually it is around 3 cm wide, but thinner patients or female patients it can be smaller. Usual graft harvest is around 10 mm of width. Sometimes it can go to 8 mm or 9 mm, that is okay. Try to keep at least 9 to 10 mm of remaining tendon on both sides of the graft harvest. So you mark the harvest, the area that is to be harvested, the thickness that is to be harvested, and you go with 15 blade. I like to go with the 15 blade from inside out. You go parallel to the fibers. You are not trying to cut through the fibers. You are just trying to incise or separate the fibers and harvest the graft. So you have separated the fibers, and in this illustration I have already actually harvested the tibial bone plug. So how I do the tibial bone plug harvest? If you have the luxury of having the handheld saw or the mini saw, then very well use the saw to harvest around 25 mm of length and around 10 mm of width of the tibial tuberosity. But if that is not possible, you can very well use multiple drill holes all along the line and use osteotomes in order to break it open. The tibial plug is usually triangular in shape, not square in shape, so that you don't tend to go posteriorly in the tibia. There is very low risk of fracture, iatrogenic fracture to the shaft of tibia. So that is after harvesting the tibial bone plug, and you have also inside and separated the tendon from the rest of the tendon. Then you have the remaining patella bone plug that is to be harvested. So again, you can do the patella bone plug harvest with mini saw with your hand. Again, aim at around 23 mm of length and 10 mm of width. But if you don't have the saw, it is okay. I have been doing the drilling technique for almost all of my patients, go around 7 to 8 millimeter deep with your drills. Don't go through and through into the posterior articular surface of the cartilage, and then you can use osteotomes both posteriorly, that is on the deeper side. You can lift off the tendon. You can lift off the tendon and go with your osteotome horizontally to the patella with the knee in extension, after making horizontal drill holes halfway through the patella, and then use 8 to 10 millimeter narrow saw to go horizontally under the bone and place it there, and you go with anteroposterior osteotomes on the medial and lateral aspect of the graft harvest. So finally you have a graft that is harvested with the tibial plug and the patella plug. You size it. It should not be too big. It should be sized appropriately. Usually 8 millimeter or 9 millimeter is good. 8 millimeter for beginners. And then you go ahead with closure of the donor area. Always try to approximate loosely the patella tendon and always close the paratenon. You don't want adhesions. And then you close the remaining soft tissue with one vicryl and 2 vicryl and something for the skin. As far as the fixation is concerned, you go ahead with preparing the bone plugs with drill holes, because you need to pull it through into the femoral tunnel and also maintain it on the tibial tunnel in order to do indifferent screw fixation. I do not like suspensory fixation for my femoral bone plug, because you have a square shaped graft sitting inside a cylindrical tunnel, and that is not going to give good approximation. When you have screw fixation, you have very good tight approximation on the femur, and then again screw fixation on the tibia. So, pearls and pitfalls: avoid midline incision in order to avoid pain with kneeling and also to facilitate tibial screw fixation. Do not oversize the graft or undersize the graft. Avoid forceful maladies. You don't want fracture in the patella. Bone graft donor site can be grafted in order to avoid pain, anterior knee pain. Biomechanical studies have shown that bone patella tendon bone graft have the best biomechanical benefits, and the healing is also better. So the key takeaway: DPTB autograft remains a gold standard. Meticulous harvesting techniques is very, very important, otherwise you can land up in complication. Proper graft preparation is required. Patient and surgeon factors are important for graft selection and outcomes. So that's about BPTB graft. I would like to take this opportunity to welcome all of you to the Chennai Sports Injury Conclave that is going to happen on June 14. As part of the second World Orthopedic Concern National Conference, we have a lot of fellowship options, not only in arthroscopy but also in spine and arthroplasty and trauma in Chennai, Bombay and Calcutta by leading senior surgeons. And we also have paper presentation options for you. We have a lot of international faculty, including the second vice president of ISACOS, Dr. David Figueira, and a very good friend of mine, the president of SICOT, and the past president of WOC UK, Dr. Alberto Bigori, and a lot of other leading surgeons speaking for the conference, and a lot of learned expert national faculty traveling down to the conference. So, welcome all to Chennai Sports Injury Conclave. Thank you very much.
Thank you, sir, for that highly informative and skillfully presented session on bone patella tendon bone grafting. The detailed explanation of the technique, graft handling and surgical pearls has made the session extremely valuable and clinically relevant for all of us. I humbly request the chairpersons to present the mementos to our distinguished guest speakers for today. I request Dr. Rajagopalan sir to kindly present the memento to Dr. Gopi Shankar sir. Dr. Rajagopalan sir and Jayakumar sir to kindly present the memento to Dr. Adil Kumar sir. I request the chairpersons to kindly present the mementos to Dr. Aravindan sir. I request the chairpersons to kindly present the mementos to Dr. Sasinder sir. Thank you, Dr. Rajagopalan sir and Jayakumar sir. We are truly grateful for your presence today. We will now take a short tea break for refreshments and reconvene shortly for the next academic session. I request all the delegates to kindly take their seats for the commencement of the next session. I request Dr. Arvindan sir and Dr. Gopi Shankar sir to kindly chair the session. I now call upon stage Dr. Satish Kumar sir to talk about newer graft options for ACL reconstruction, quadriceps and peroneus longus.
Good morning everyone. I sincerely thank our Puducherry Association for giving this opportunity to talk. So it's a slightly elaborate talk. I'll try to stick to my time limit. So I'll be talking upon superficial quads, bone quads and peroneus longus. So we all know that for ACL we have several graft options available, and till date we still say that according to the literature BTB is still the gold standard. And hamstrings and peroneus, as we know, are very commonly used. So the quadriceps graft was not very extensively researched or used graft till I think past 5 years. Now there is a recent interest in quadriceps graft, and since it is a soft tissue graft, it can be used as an alternative for patella or hamstring graft and peroneus graft. So there are several types of quadriceps grafts. I'll go into them one by one. So what is the biomechanical rationale for using our quadriceps graft is that quadriceps graft has a higher cross-sectional area, twice that of BTB, and the type 1 collagen is 90 to 95%, which gives high tensile strength, and there is a higher load to failure and greater stiffness of the graft, and versatility. Quadriceps you can use as a bone quadriceps, central quadriceps or superficial quadriceps. I'll go into them one by one. And the graft size is relatively more predictable compared to hamstrings. So there are three types of quadriceps graft. One is superficial quadriceps graft, and one is bone quadriceps graft, and another is full thickness quadriceps graft. So we are seeing the bone quadriceps graft. So in bone quadriceps graft, we take a part of the patella along with the quadriceps tendon, full thickness. And then there is a central quadriceps tendon, that is CQT, where we take only the soft tissue part, full thickness quadriceps graft without the bone plug. And then we have a superficial quadriceps where we take isolated rectus femoris tendon. So in the image you can see there are three grafts. First is the bone quadriceps tendon, second is the superficial quadriceps tendon, and third is the central quadriceps tendon. So techniques, we have a Indian paper for harvesting the superficial quadriceps tendon by Dr. Rajiv Raman sir. So the incision is vertical incision proximal to the superior pole, and we use a toe stripper in this graft harvest. So the stripper that we use normally for ACL is 7 millimeter. So we need to note that we need a 8 mm stripper to use take this graft. And then we have another paper, a Vietnamese paper by Nguyen et al., where the incision is horizontal, more proximal, and they use open stripper. So there are two techniques to take this. So whichever suits, we can follow that. So my preference is I take a horizontal incision, 2 finger breadth above the patella. So once opening that, you can see that with the right angle artery, we can easily isolate the rectus femoris graft. We need to take 10 to 11 millimeter horizontal width along with 0.5 mm depth. So after that you put the right angle, you will be able to nicely elevate this tendon. So this video I am showing a demonstration of using the open stripper for using harvesting the superficial quads. So you can use both open stripper or closed stripper, that depends on the comfort of the surgeon. So this is how the harvested superficial quads looks like. So you can see that the length is very good, and if you triple that you get a very good diameter of the graft. So this is how prepared graft looks like. So one common apprehension with quadriceps graft is that SLR may get affected. So this is a video of a patient POD2 SLR. You can see that there is no disturbance in SLR after taking the superficial quads. That is the advantage of this graft. So the advantages is that by taking a hamstring graft, we all know that we create a flexor weakness in the patient, and especially in athletic population who did sprinting, I don't think hamstring is a good option. And another advantage is that you get more consistent graft length and diameter, as I had said before. Hamstrings is slightly unpredictable in this aspect. And learning this graft gives you an additional option of taking this graft in multi-ligament scenario, because in multi-ligament we need multiple grafts. So if you know to take this graft, you get additional 2 options from the same side and the contralateral side. You can take this graft for a multi-ligament scenario. And level 1 evidence currently suggests that the outcomes are non-inferior compared to hamstrings. So this is the latest literature taken from November 25. So for return to sports, they are saying that after BTB, quads has a very good return to sports compared to hamstrings. So disadvantages, not too many disadvantages. Only thing is data is limited. We don't have a 10, 15 or 20 year data like hamstrings or BTB. And there is a small learning curve associated with the graft. And in short stout individuals, which is a common scenario that we see in our population, typically the middle-aged housewives. So in that kind of patients, this graft again may give the same problem like hamstrings, that you may not get adequate length or diameter. Coming to the bone quadriceps tendon. So before going into the tendon, we need to know the average thickness of the patella. So you can see that for a male it is around 20 to 26 mm, and for female it is 16 to 22 mm. And if you add cartilage to that, you get another additional 5 mm. So how much bone are we going to take in this bone quads is that we take usually depth of around 10 mm. So this is the marking. This is how you take the bone quadriceps tendon. You need a vertical incision to make it little easy, and then we mark the patella, how much length and width we need. So 10 mm width and 2 centimeter length, and again depth another 10 mm. So one good thing, one small tip for taking the graft is you can mark the drill bit, how much depth you want to go. Here I have used a sticker to do that marking, so that you don't go too deep inside and fracture the patella by taking excessive depth. So while taking the graft, we need to be careful. Another way to take the graft is you can just keep only 10 mm of the K-wire in the drill, so that you don't go beyond that depth. So after drilling multiple K-wires, you use the osteotome to harvest the graft, and then use the knife to extend the harvest the graft along with the bone. So this is how bone quads looks like. The normal length that you get with the bone quads is around 8 to 9 centimeter, which is reasonably good enough for doing the ACL reconstruction. So bone diameter, my preference is usually I keep it at around 8.5 mm, and screw size for the femoral side I bring it down by 2 sizes. Take 7 mm screw. So this is how bone quads looks like after putting it in the joint. So that is the peak screw. I usually use peak screw. Bio screw have a small tendency to break, and this is how the graft looks like. You can see that the graft is quite rigid. So advantages is that less chance of graft lengthening, because you are putting aperture fixation both sides. So the common issue with soft tissue grafts is graft elongation that you won't encounter here. Useful for athletic and obese population. Less kneeling pain compared to BTB graft. outcomes are equal to BTP graft for primary and revision ACL according to the literature. Disadvantages, again, this has a small learning curve, and there is a risk of patella fracture if we go too deep. And in rare documented scenarios, there is a quadriceps rupture also post-operatively for the patient after taking this graft. And long-term studies are definitely lesser compared to the BTP graft. To summarize, quadriceps is a versatile graft. You have usually good outcomes. Superficial quads is a good alternative for soft tissue graft, and bone quads is a good alternative for bone graft. And quads weakness is a small issue with bone quads, not with superficial quads, and more long-term studies are needed. Perennials, we all know it's already established graft, so I'm not going too much deep into it. So just wanted to show the current evidence on perennials longus. So the current evidence says that functional outcome is largely comparable to the hamstring graft, and it provides a larger and more predictable diameter. That is an agreed point by everyone. And preservation of hamstring strength, because we are taking from the ankle, no need to worry about the flexor weakness. And donor side ankle morbidity is generally low, and biomechanical properties are good. And long-term evidence, however, it remains limited compared to BTP or hamstring, because I think only in India we are using this graft very regularly. Europeans and Western surgeons still have that tendency to not take hamstring because they believe, not take perennials because they believe it's a very important structure in ankle. And current evidence, perennials longus is not an experimental graft anymore, it is an established graft. Long-term high-level evidence is still evolving. So some common indications is that wherever we have a small hamstrings, you can use this to augment our graft, and useful in revision ACL scenarios, and again in multi-ligament scenarios. Whenever you need a thicker graft, you can go for this. And wherever we need to avoid hamstrings, you can use this. So limitation, as I told, long-term outcome studies are limited, and there is a potential subtle ankle function deficit, and less extensive evidence compared to BTP or hamstring graft. Thank you.
Thank you, sir. Your insights on the quadriceps and peroneus longus grafts have broadened our understanding of evolving techniques and current advances in ligament reconstruction. I now call upon stage Dr. Prahlad Kumar Singhi, sir, HOD of Department of Orthopedics, Preeti Hospital, Madurai. He shall be talking about tips and tricks of ACL surgery.
Good morning at the outset. I thank IAS One DNOA President Sir, Sundarajan Sir, and the organizing team here, Natarajan Sir and Manikandan, for having me here today. So we have seen beautifully all the techniques, tips and tricks demonstrated today by Sundarajan Sir for ACL reconstruction in his live surgery. So it will be just brush up of this same thing. So we'll just go through again the same things here. Okay. So I am Dr. Prahlad, consultant at Preeti Hospitals, Madurai. So I have nothing to disclose. So I would like to share these following tips. So it is very important to know the anatomy, know your patient, clinico-radiological assessment is very important. Know your team, allot responsibilities for each and everyone so that the entire procedure goes smoothly. So the most important is again to evaluate under anesthesia, to look for the associated injuries, and then you can plan your surgery. The graft selection and technique and tunnel placement is again very important. I would like to share a few of these tips here. So meniscus preservation and associated injuries is very important for the outcome of your successful ACL reconstruction. So addressing these associated injuries is very important. The fixation technique, the rehab is the again key for the successful outcome. So we'll see individually. So we all know the anatomy of the ACL reconstruction. So it is again made up of two bundles. So it is practically not possible to create an anatomical ACL reconstruction. We can produce a near like structure. So we had seen beautifully today, Sundarajan sir has demonstrated where exactly you want to have your ACL reconstructed. So this ridge, the bifurcate ridge, and this is the lateral intracondylar ridge. So this point is most obvious when we try to do hyperflexion. So this is the reason why we have to do hyperflex, and so that we can get the anatomical point for taking up an entry. The microanatomy of ACL is very important, because nowadays we talk about repair, whether we can repair an ACL. It is only the Sherman type 1 and 2 type of tears are amenable for repair, and you can always try to repair whenever possible. And to know your patient, it is the most important part, because you will have to clinico-radiologically assess your patient. Without seeing your patient, don't take up him to the OT. Make sure that you have seen the patient, you have assessed him clinically, and also the demands of the patient is very important, whether he is a sports person, whether he is a hard-working labor, so that your protocol may change when you are based on the activity of the patient. So the associated injuries, so the individualization has to be made based on the patient. So these patients usually, it is again whether the patient has presented acute or chronic injuries has to be identified, and also you have to see the radiographs. It may give you certain features like Sigon fracture or some avulsion fractures associated can be picked up. And again you have to read your own MRI. Sometimes you will pick up the things better than the radiologist. So based on the duration, if it is an acute tear or chronic tear, you try to take the patient for the surgery. For me, the patient should be actively able to do complete range of movement, and he should be doing active ROM. So then we will be able to take him for the reconstruction. So this looks a complex slide for your management, but this is very important. You clinical radiologically you assess, so that you plan your surgery according to the associated injuries. So know your team. This is what I want you to understand, that you should explain all the steps for your entire team. You know all the instruments, you know how you have to position the patient. So today we saw the sir was telling you what are the various ways we can take the portals. So your team should be well versed with the steps. So then the procedure will become very smooth, and you can make it in time. So evaluation under anesthesia is very important. You have to do all the tests again, because sometimes when the patient is awake, it is difficult to evaluate all the tests. So you do the Latchman anterior door. Sometimes you should feel for the any sag is there. So the pivot shift is most often evaluated under anesthesia, and if it is positive and high grade positive, then you should think of adding an LET for this procedure for the patient. And again, varus valgus stress, based on this you will assess whether there is a anteromediolateral or posteromediolateral injury. Coming to the graft, so we know that Satish has beautifully explained about the various graft options. So we have autograft. Allograft are not commonly available in our scenario. Nowadays we have dual ACL, but standalone dual ACL is still not an indication for me. So I used most of the time autografts. And hamstring remains my favorite choice of graft, then BTB. So coming to ACL reconstruction, we have seen that there is an evolution of various techniques, but for me, again, the single bundle standard ACL reconstruction is my preferred, with suspensory fixation and screw on the tibial side. So this is the conventional technique, and today we will also try to demonstrate the all-inside technique, which is a bone conservative technique. So where we conserve the bone. So as we discussed, the associated injuries is very important. You have to be, there is a significant portion of these associated injuries. If you don't address them and treat them, you will not have a successful outcome. So the diagnostic round is very important. You do a diagnostic today. We saw sir was identifying those tears. So you should see there is a complete ACL tear. though this meniscus looks small, but when you probe it, it is an unstable. So you should plan that, you should need to do something for that also. So accordingly, you can allocate your time. So because there is several things to do, there is a medial meniscal tear, lateral meniscal tear. So you have to plan your procedure and allot the time so that you can finish them in time. And this is how I harvest the hamstring graft. So we have seen sir giving all the tips and tricks today to harvest the graft. This is one of the way you can prepare the graft here and put it on the tensioner device. You can use vancomycin wrap or gentamicin wrap for the thing. So we saw sir was demonstrating about the use of femoral jig aimer for taking up the tunnel. So hyperflexion, if you see here, so when you hyperflex the knee and you can come to an accessory portal, you get the best trajectory for your femoral tunnel. So you can do a femoral tunnel ream up to 40 with the endo button reamer and then decide depending upon what type of fixation you prefer. So on the tibial tunnel, again, I have used the footprint aimer. You try to get that at the right slot and then you do a sequential reamer. Here again, the sequential reamer will help you to adjust whether you want to go medial, lateral or more anterior, posterior, so that you get a good tunnel. So again, the passage of the graft is very important. You should try to see and confirm whether the button has flipped. There are various ways you can identify by seeing through the more medial portal or by again pulling once the graft has gone in. So then you start cinching the graft. Once the graft is cinched, then you can fix it with a screw on the tibial side, and you can use, and as sir mentioned today, you can use one size screw if your tunnel is filling the graft, or you can use a bigger screw when there is a graft tunnel widening. And then you can always feel for the tautness of the graft. So for me, there is aperture suspensory fixation on the femoral side and aperture fixation on the tibial side is my preferred technique. Sometimes you can choose other devices based on the patient factors. Particularly the female patient, they have a shallow notch and small tunnels, so you can use a suspensory fixation on both the sides. So we are aware about the bungee effect and the windshield wiper effect. So when we use suspensory fixation, we are prone for bungee effect, and when we use aperture fixation, a wind wiper effect, windshield wiper effect can cause the concern for your graft. So this is another way you can prepare the graft when you are using an all-inside today, which we will demonstrate here today. So where you have to prepare it in a different way, and once you prepare this graft, you can the tunnels making on the femoral side will be the same, and on the tibial side you will have to use something called flip cutter and make the tunnels, and we will see it today in the live surgery. So the role of internal brace, you can augment if your graft is little smaller diameter. The minimum 8 mm diameter is what we expect to have. So this gives you a seat belt effect. So the again most important part of the successful outcome for the surgery is the rehab. So there are various rehab protocols. There is aggressive rehab protocol and the standard rehab protocol. So this is what we follow, which has 4 to 6 up to 9 months. So the return of the sports should be up to 9 months. So the rehab is very important. So the take-home message for a successful ACL reconstruction, because we do this procedure common. So the clinical radiological assessment is most important. Identify the associated injuries and address them, and see what technique of fixation works best in your hand, and for your patient you can decide. Thank you.
Thank you, sir. Your surgical pearls and real-world operative guidance will certainly help us improve our understanding and execution of the procedure. I now call upon stage Dr. Shantamurthy sir, Senior Grade Consultant, IGGH Puducherry, to enlighten us about introduction of operative and post-operative complications and how to manage them.
கால் லைன் வரேன் அவங்க கரண்ட் அப்புறம் உங்களுக்கு லைன் வரும் நீங்கள் போயிடுங்க ஸ்பாட்டுக்கு போயிடுங்க
Good morning, one and all. So today my talk will be on complications related to arthroscopic ACL reconstruction and its management. So in general, arthroscopic ACL reconstruction is a safe procedure with the least complications, but most of the intraoperative complications occurs due to technical errors in the learning period, and the most serious complications are the one with the neurovascular injuries, arthrophyrosis and infections. So one should be aware of these complications and it should be managed appropriately. So in general, we divide the ACL reconstruction related complications as intraoperative and post-operative complications. So coming to intraoperative complications, based on these parameters, we can divide into three: graft related, tunnel related and implant related. So post-operative complications can be divided into early and late. So coming to intraoperative complications, I will see one by one. Complications related to graft harvesting, that is with regard to hamstring tendon harvesting. You can encounter short hamstring grafts if you are not sure of whether you are cutting the vinculae or the tendon itself. So you should always check out for the vinculae. And if you inadvertently cut and it is short, then you have to look for the other alternative grafts for the same from the same ipsilateral knee, and also you can use allograft if you are consulted from the patient. Also, you should be aware of accessory semi-tendinosis. When if it is there, again you may get a short graft. So in those scenarios, people nowadays advocate outside-in technique so that you can avoid these complications. Another complication related to hamstring tendon graft is injury to the infrapatellar branch of saphenous nerve. Usually it will recur over a period of time. So people advocate more horizontal or oblique skin incision to avoid this injury than vertical skin incision. So coming to patellar tendon harvesting, the commonest complication encountered with the patellar tendon harvesting is thin bone plaque will lead to patellar fracture. So usually you should use a beveled edges for the taking patellar tendon graft, bone plaque. Use a saw at 90 degree to cut the bone and shoot sharp and use sharp osteotomes, slowly elevate the bone plaque. So suppose if at all you encounter a fracture, then you should be in an appropriate place, use implants to fix that. And you should delay the rehabilitation. So complications related to graft passages, you may get either too thick graft where you will encounter difficulty in passing the graft in the tunnel. So you have to remove the soft tissues as morning demonstrated by Sundarajan sir. You have to widen the entry point. Sometimes you may use a dilator or a drill. If the graft is too thin, then you may have to use a interference screw or along with the suspensory fixation. So graft contamination is rare, but if it is occurs, it will be detrimental or it may cause infection. So always secure the graft using artery forceps in the site table. Suppose if at all inadvertently it falls down and contaminated, you should use for alternative grafts, or if it is not consented, then you can use a chlorhexidine solution or polymyxin B bacitrazine solution and use the same graft for the patient. Then graft laceration is a serious technical complication again. It can result in partial or complete failure of the graft. So one should expect lacerations whenever you are using interference screws, and you should maintain the tension of the graft. Otherwise, if you fix it in a loose without tension, the laceration chances are more, and you may have to revise with another graft and fixation. So coming to most common complication and technical failure is a non-anatomical placement, as highlighted by Sundaraj in the morning live demonstration. Here you can see that a non-anatomical tunnel is placed on the femoral side. So there has been clear-cut landmarks described for the tibial as well as femoral tunnels. One should aim for this, as also today highlighted by Pragladan sir. Another landmark in sagittal plane is Amish-Jacob line. So you should aim for the tunnel should be parallel and below to the Blumenstein's line, and the position should be at 43% anteroposteriorly. So the clinical significance of non-anatomic tunnel is it may result in motion deficit and graft failure. So if you fix the graft more anteriorly, you will get a loose graft in extension, and if you fix the graft more posteriorly, you will get a laxity in the flexion. Similarly, you may get impingement if the graft is placed more anteriorly, and if it is too posterior, it will cause irritation over the PCL and impingement and graft failure. So again, vertical graft results in rotatory instability, so you should aim for a more horizontal graft. So how to prevent it? You can use a scale intraoperatively to measure the footprint location, or sometimes you can use fluoroscopy. So if inadvertently create a non-anatomic tunnel, on table you can use create a new anatomic tunnel, and you can leave the original tunnel. Or if the original tunnel is also coagulating, then you can use a larger screw or a bone graft. So next complication is posterior wall blowout, which can occur during the femoral tunnel creation. So this is another serious technical error, and mornings are told you have to look for the anatomical locations, and you have to leave at least 2 mm posterior cortex to avoid the blowout. So technical tips to prevent is you can use you have to use always a high flexion to avoid the blowout, and you can drill 2 to 3 mm initially, withdraw and see evaluate the stump created on the femoral condyle, and then go progressively looking for any posterior wall impairment. So always try to use the specified offset jigs for the femoral tunnel drilling, as morning demonstrated by sir. So if at all you inadvertently create a posterior wall blowout, you can use several tips and tricks. One is you can use over the top fixation using a screw and washer on the lateral femoral cortex by opening on the lateral side. Another method is you can retain the same tunnel opening, and you can change the trajectory and create a new tunnel in the entry of the original tunnel. So this is a short video. In this we can see that once you encounter the posterior wall blowout, so here you can see the posterior wall blowout has happened. So you use a ACL jig, create a new tunnel, changing the trajectory from anterolateral to posterior. So drill the guide wire, ream it, and now we can pass the graft through the new tunnel as usual. Also, you have to use a additional screw fixation on the femoral side in this scenario. So that is regarding one technique for management of femoral blowout, posterior wall blowout. The next complication is screw divergence. This can happen many times if you are not attentive in passing the cannulated screw using a nitinol wire. The acceptable screw divergence is 15 to 30 degrees. Anything more than that will result in the graft failure later. So if you detect this problem post-operatively, use a functional cast and delay the rehabilitation program. Screw breakage is common with bio screws, as morning it is demonstrated by one of the faculties. So you have to use a dilator before passing the screws when you are using bio or PEEK screws, and use a smaller screws if necessary. Then another complication is inadvertent injury to the medial femoral condyle when reaming when you are using the anteromedial portal. So best way is to avoid by visualizing the reamer when you are passing whether it is hitting the medial femoral condyle or not, or you can use specific sheets given by the certain companies. If the inadvertently it occurs, if the lesion is very small, you can leave it alone. If it is large, then you have to use a microfracturing. Next complication can be inadvertent over drilling of the femoral tunnel in case of using endobuttons. So in those scenarios, you can use a extension button to increase the length of the button so that it can flip and stable, or you can additionally use a interference screws. Another complication is eye button flip. It happens inadvertent pulling of the endobutton outside the tensor fasciolata. So here, if the graft is stable, you can leave it. Otherwise, better to revise it and bring it down. And you have to follow a less aggressive rehabilitation. Sometimes what happens, a low button flip, that is before the button flips in the tunnel itself. So you should, if you have a suspicion, you should use a SIAM. So morning as sir demonstrated, you have to mark the tunnel length and the graft flipping length and all to avoid these complications. So coming to post-operative complications, tunicate palsy is the most avoidable complication. So one should restrict the time, and the vast majority of the time it is recoverable. But sometimes you may have to use a surgical exploration if it is not recovering. Coming to neurovascular complications, it is rare, but when it occurs, it is dangerous. So you have to be cautious of clinically examining the patient post-operatively, avoid excessive drilling, posterior drilling. So appropriately you have to treat if it is occurring, either vascular surgeon or neurological management based on the nerve injury type. So DVT is again preventable complication, as you all know. Hematoma formation is rare, so when stripping the hamstring, you should be stripping at the musculotendinous junction rather than at the muscular region. Cyclope lesion also occurs in patients who are having a delayed rehab. So you have to attain extension rapidly, and you have to do a aggressive rehabilitation. If cyclops ensures, then you have to do excision arthroscopically. So arthrophyrosis again a preventable complication. Here you have to be very cautious. If you leave it, then again patient may have a delayed recovery. So you should use aggressive rehabilitation. Infection is detrimental, so it can result in disastrous knee arthritis. So you should use all preventive measures like intravenous perioperative antibiotic prophylaxis. As morning demonstrated by Professor, you can use vancomycin soaked grafts. So if you encounter a serious infection, you may have to remove that and do a 2-stage revision ACLR. So complex cerebral pain syndrome is rare, but once it occurs, it may have a delayed recovery. You need a multidisciplinary approach. So implant breakage has been demonstrated. It can happen in patients. If the patient is asymptomatic for some time and suddenly coming up locking and all, you should suspect this complication. Prominent tibial screw can occur. If the graft is stable, you can delay the removal of the screw when the graft becomes integrated. Tunnel widening is a late complication. It's not an immediate threat, but it can have a problem in the revision. Thank you.
Thank you, sir. Your practical approach towards prevention, recognition and management of these complications was extremely valuable for all of us. I now call upon stage Dr. S.R. Sundarajan, sir, to talk about ACL avulsion injuries, consultant in orthopedic department at Ganga Hospital.
Good morning, everyone. So, my talk about the anterior cruciate ligament avulsions. It's not just tibial avulsion, you can have a femoral avulsion also. It's not very common, but you can have, this is the incidence of around 3 per around 100,000 per year. And age, usually pediatric population is more common than adult population, because adult you have a ACL tear, in pediatric population you have a more of avulsions from the tibial side more often. And it occurs secondary to the forced flexion of the knee with the internal rotation of the tibia. I think the anatomy is the key when you do when you look for the ACL and PCL avulsion, especially for a beginner or a postgraduate. All the tibial eminence fractures are not same. Okay, so if the tibial eminence is the big portion of your central portion between the medial tibial condyle and the lateral tibial condyle. So what you are looking for is that the ACL avulsion is just in front of the eminence, where you have the fibers of ACL attached to that, as we saw in the morning, and the PCL is just posterior to the articular surface of your tibial articular surface. So the inter eminence here is completely doesn't divide off any soft tissue attachment. So any this eminence fractures we always treat conservatively. We try to operate only in ACL avulsions and PCL avulsions. So we will concentrate on ACL avulsion. There are many types. I think Bayes and McKeeves have classified. Again, we don't operate all these patients. Like type 1 and type 2 with mild displacement, we don't need to operate at all. Unless it's displaced completely, it is not attached to the bone, then we should try to fix it up. If it is even slightly have a posterior attachment and anterior is tilted up like that, still you can just treat conservatively with some hyperextension cast, or you can put a just hyperextension brace for 2 to 3 weeks time. That is good enough. That is good enough for your ACL avulsion to heal well. What happens if you don't fix the displaced avulsion? So these patients will lose the extension. They have a pain in extension. They can have a mild instability also. You can see this is a 7 years old child. Had a fall 6 months before, managed with the plaster cast, not properly managed, and you can see this patient ended up with a fixed flexion deformity like this. This is a big problem to treat, because you can have that even if you treat after 6 months, we can get an extension still, but still it's not possible to get a normal knee. So it's very important that identify that ACL avulsion which is displaced like this, where you have a big displacement from the bone. This has to be fixed, because otherwise the bone doesn't allow the knee to get into the neutral or hyperextension. I think all of you are aware that our knee is not just zero, you can have a hyperextension. So you should try to get that same movement what you got on the other side. That's what very important. So we should not end up like this. You can see that how much is almost 30 degrees of fixed flexion deformity in this case. So the restricted knee extension is the major catastrophic complication in ACL avulsion, not the instability. And this non-union is one of the most important complications. So anything with the displaced fractures, you should treat well. This is a 12-year-old girl with completely displaced avulsion in a pediatric population like this. How to treat it? So when you have a lot of options for this, you have screw options, suture fixation, suture button fixation, staple anchors like that. In pediatric population, you cannot use the screws because you are going to cross the physis, which you don't want. There are two other way of fixation. One, you can use staples. The major obstacles in doing the reduction is once the fragment gets avulsed, your meniscus moves posteriorly. So you can see that the meniscus is not allowing, it is falling anteriorly, posteriorly. So you have to bring it back like this using a probe. So always try to use 2-3 portals extra, put on one more portal, use the probe to reduce the meniscus into the position so that your fragment go and sit over there, then you can start doing the fixations. So that is one of the major obstacles is the medial meniscus, which can get trapped between these two fragment and the tibial bed, or the transverse meniscal ligament, which is connecting your anterior horn of the medial meniscus and the lateral meniscus, or sometimes anterior root of the lateral meniscus. So always the anterior root of the lateral meniscus is attached to this fragment. So you have to reduce that anterior horn of the lateral meniscus. That many way of doing the fixation, as I said, this one way is that you do a temporarily fix with the K-wire. You can reduce it with many ways. You can try to do a hyperflexion, to do hyperextension to see which position the fragment sits well. Then you can also try to reduce this kind of notches like a L punch where you can just gently hit it so it will go from anterior to the posterior to the bed. It is not possible when it's a comminuted. When they have a big single fragment, then you can reduce it easily like this. Then you can use a staple fixation like this. This is one of the fixation which I used to use earlier, maybe from 13 years before. Now I stopped using it, I will tell why. But this is a very good instrument for a pediatric population where you can see this is the anterior horn of the lateral meniscus, that is the avulsed fragment. So one staple will hold the anterior horn of the lateral meniscus with the fragment. Then another staple is used to fix the remaining big fragment of your ACL avulsion. So this is the very good advantage because it doesn't cross the physis and it have a very good fixation. So only problem is sometimes it can loosen up in the future. So that is the only complications which you can come across the staple. So this is one of our publications in the Indian Orthopedic Journal published in 2011, very long, you know that now it's almost 15 years. So I don't use it anymore because of these complications like this. You can see it is migrated. Sometimes even I had removed some staple from the posterior compartment. So now we have a better fixation like a suture pull-out technique. So we don't use it anymore. So when you have an avulsed lateral meniscus with the fragment like this, what you can use you can use the anti-grade device like this, use the suture tape. Then that can also help you to pull the lateral meniscus to the original position. So that will help you to bring your fragment to the bed. So it is very important that you have to bring it. You can see that when you pull it, the whole fragment moves over there. So it is ideally that sutures also can be incorporated in your fixation when you fix that ACL avulsion. So that gives extra stability when you do the fixation. So that is how we do that. We take 1 or 2 steps like 2 bites. Then you take using a lasso or you can use the anti-grade device Scorpion to take the bites through the ACL with the suture tape or a fiber wire. Then you can use the 2 tunnels on one. I usually one on the medial side, one on the lateral side, one on the medial side, and bring it outside and suture it in the tibial cortex. So this is how you end up with the final fixation. So it's very important to reduce perfectly because these fragments can cause later on, if you are allowing the fragments to float, then possibly they can have a pain in extension or they can lose the extension. So it's very important that you pull back and reduce it perfectly. You can use even 2 tunnels like this. Separately, you can use a separate fixation for anterior horn of the lateral meniscus and separately for your ACL avulsion. This is another 12-year-old boy football injury. And you can see that here I am using a different method of fixation because it's a 12-year-old boy. We cannot use the suture pull-out because you have to make a 2 tunnels through the physis. So you don't want to take a risk of growth issues. So sometimes what you can do that in these cases, you can take these suture tapes and also you can use this kind of fixation where you can use an anchor. You can use the shoulder where we use the lateral row anchors, knotless anchors, where we take bites on the both the sides. You can use the one lateral row on the medial side, one on the lateral side, so that will give you nice fixation and you don't need to worry about your physis issues here. So this is the anchor fixation. So when I compare the kind of fixations between the sutures and the suture pullouts, it is very important that these patients, you should not use the screws here because you have to remove the screws again. That is a problem. This is the comparative study where you can see that screw fixation had a large number of re-operations. So we don't use the screws anymore now. I use only the suture tape with pull-out technique, or I use the anchors to use in pediatric population. I stopped using the staples also. This is a systemic review. You can do open also. It doesn't matter if you are an open surgeon, you can still do the open. But the advantage of arthroscopy is that you don't have all the patellar fat pad issues and all those things. It's a quick visualization. Reduction is easier and your rehabilitation is quicker also. So suture pullout is the most commonly which we use now. But you may immobilize them for at least 2 to 3 weeks in extension, so that you don't have a problem of losing the fixations. So this is a 12-year-old boy. You can see this is a very rare injury where you get the femoral side avulsion. So you can have a femoral side bony avulsion like this in a pediatric population, but it's not very common. But you can still have. You can see that CT scan showing the fragment, very thin flake of fragment with avulsed with your ACL. So this is you can use it like regular ACL repair, where you can use the multiple fiber wires. You can take stitches through your scorpion. And usually I use like fix with 2 lateral anchors, one on the like anteromedial, above the anteromedial bundle, one anterior to the posterolateral bundle like this. So that can have a very good strong fixation because it's got a bony piece. The very good 100% chance of healing is there. So in the pediatric population, it can be repaired nicely and fixed with a repair like this in the fiber wire. To conclude, as I said, that all the tibial side avulsion, type 1 and type 2 can be treated conservatively unless it's completely displaced. You have to do the fixation by arthroscopically. And it is very important to do the fixation to avoid the fixed flexion deformity and instability in the future. Most of the adult patients we do with the suture fixations. In pediatric population, still you can consider staple, or you can use the anchors which we use for our knotless anchors so that you don't cross the physis. And femoral peel off from the bone from the femoral side can be fixed with the knotless suture anchors. Thank you very much.
Thank you, sir. Your detailed discussion on diagnosis, management and strategies. I request Gopi Shankar sir and Aravindan sir to present the mementos to Dr. Satish Kumar sir. I request the chairpersons to present the mementos to Dr. Shantamurthy sir. I request Dr. Krishna Gopalan sir, Organizing Chairman, to present the mementos to Dr. S.R. Sundarajan sir. request Dr. Krishna Gopalan sir to kindly present the memento to Prahlad Kumar Singhi sir. We would now like to start the inauguration ceremony. I would like to invite the following distinguished guests to the stage. Dr. S.R. Sundarajan sir, President TNOA and IAS Course Director. Dr. Prahlad sir, HOD, Department of Orthopedics, Preeti Hospitals. Dr. Krishna Gopalan sir, Organizing Chairman. Dr. Vijay Raghavan sir, President PAO. Dr. Gopi Shankar sir, Dr. Shantamurthy sir, Dr. Manikandan sir, Organizing Secretary. With great pride, I now request everyone to rise in tribute to our Tamil language and culture. Let us evoke the feelings of reverence and devotion as we celebrate our rich linguistic and cultural heritage through the Tamil Taiwal. Thank you all. I'm pleased to call upon stage Dr. Vijay Raghavan sir to deliver a welcome speech on behalf of all our esteemed dignitaries present here today.
அனைவருக்கும் இனிய வணக்கம். மதிப்பிற்குரிய தலைவர்கள், ஆசிரியர்கள், மருத்துவர்கள் மற்றும் அன்பு நண்பர்களே, உங்களை அன்புடன் வரவேற்கிறேன். It gives me an immense pleasure and privilege to welcome you all to the IAS TNOA Joint Preservation Program on Mastering Knee Arthroscopy and Joint Preservation, organized under the aegis of Indian Arthroscopy Society and Tamil Nadu Orthopedic Association and Puducherry Orthopedic Association here at IAS Puducherry. At the outset, I extend my heartfelt welcome to all the distinguished dignitaries, eminent faculty members, consultants, postgraduates, and delegates gathered here for this important academic event. We are honored to have with us Dr. Sundarajan sir, the President of TNOA and IAS and the Course Director for today's program. He is regarded as one of the pioneers in arthroscopy and sports medicine in India, whose contribution to ACL reconstruction and sports injury management have inspired many orthopedic surgeons across the country. I also warmly welcome the President of IAS, Dr. Krishna Gopal sir, who is also a pioneer in arthroscopy and sports medicine in India, whose contribution to this field has inspired many surgeons from Pondicherry and across the country. And dear colleagues and friends, orthopedic today is rapidly evolving towards minimally invasive and joint preserving procedures. With increasing sports injuries and ligament injuries in younger patients, expertise in arthroscopy and joint preservation has become more important than ever before. Programs like this are extremely valuable because they combine live surgeries, expert discussions, practical learning, helping postgraduate students, consultants and faculty members stay updated with the evolving surgical techniques and decision making. The knowledge and the skill gained today will ultimately help us improve patient care and shape the future of orthopedics. With this small word of welcome address, I inaugurate this inauguration program and this CME. Thank you.
We shall now commence the program with the lamp lighting ceremony. I would like to invite Dr. Sundarajan sir, Dr. Prahlad sir, Dr. Krishna Gopal sir, Dr. Vijay Raghavan sir to step forward for the lamp lighting. I would like to now move forward with the felicitation program. I request Vijay Raghavan sir to felicitate Dr. Sundarajan sir. I request Dr. Shantamurthy sir to kindly felicitate Dr. Prahlad sir. Thank you sirs for inaugurating the program. I now request Dr. Sundarajan sir to give a small talk and enlighten us.
Good morning everyone. Already she told a small talk. So naturally I'm not going to give a lengthy talk. So thank you everyone for organizing this wonderful course. I thank specifically Manigandan to coordinate this program along with Sandamurthy and under the guidance of IAS President Krishna Gopal, and thank POA President Dr. Vijay. And also here I respected Rajagopalan sir is here. Sir, I see your enthusiasm in attending this whole course. Thank you sir for coming for our IAS job program. And this IAS job program, which I kept as a personal theme as a job because it's a joint preservation program, where the idea is to spread the message that arthroscopy, ACL reconstruction alone is not an Indian Arthroscopy Society is doing or the members are doing. So the idea of doing this job program is that you have to treat the joint as a whole, not like individual ligament. So when you see a knee injury, you are not going to consider just what the MRI shows. Please don't see just MRI alone. The most important is the clinical examination, age of the patient, what is the activity level of the patient, what is the status of the cartilage, what is the alignment of that particular patient. That is what important when you treat the patient. So we treat the patient as a whole. The same way you treat the joint as a whole. We don't treat as an individual ligament. That's why I incorporated in this program cartilage and the alignment, that is osteotomy, in all this job program. So that this will give you more awareness about the alignment issues and the cartilage issues when you treat with the ligament injuries. I'm sure that all this program is going to benefit all the young surgeons to know as a knee, as a whole as the sports injuries. This program is happening all over the India. Today it is happening in 4 places, not just Pandi, it is happening in Kannur, it is happening in Tirupati, it is happening in Vijayawada. Almost same program we are doing across over India with targeting all the young surgeons who wants to become an arthroscopic surgeons or who started their practice. I think these kind of programs will help you to enhance your skills, and technical tips and tricks will help you to do better in your patients. So I'm sure that all of you, if you are interested in an arthroscopic career, I would urge you to become a member of Indian Arthroscopy Society. This is one of the largest society of sports persons. That is, we have around more than 5,000 members. It is the largest society in the world now, which is having the arthroscopic surgeons. So if you are taking, and it is one of the fastest growing subspecialty in orthopedics, maybe because of all the new procedures with the availability of all the new implants and the procedure of ease and the techniques which we get learning you get so easily now. This kind of programs where it's like we go to every city to teach about arthroscopy. So I'm sure that if you are going to become a member of, if you want to take a career of arthroscopy, I would suggest to become a member of Indian Arthroscopy Society. At the same time, I would suggest you to become a member, if you're a postgraduate, you become an associate member of Tamil Nadu Orthopedic Association and Pondicherry Orthopedic Association. This is not just for the friendship, this is going to be your future long association with your particular specialty, and you can avail all the fellowships, short-term fellowships, long-term fellowships which Indian Arthroscopy Society caters. A lot of fellowships we offer from Tamil Nadu Orthopedic Association or Pondicherry Orthopedic Association. So it is very important that you should become a member of your specialty association. It is not that just I am going to practice, I am not going to do any meeting, so I am not become a member of association. That idea, if you have, please take away from you and please become a member. And once again, I thank Pondicherry Orthopedic Association and the Cholamandam Orthopedic Society to coordinate this program, and Manigandan to coordinate this program and make it as a big successful one. Thank you very much.
Thank you, sir. I now request Dr. Prahlad sir to give a brief address and share his insights with the audience.
So, good morning, dignitaries on the dais and off the dais. So, as Sundarajan sir has told, so we have to be a member of association because in today's days we have so much of things to learn and so much of things to protect us also from certain elements. So I think so IAS is one of the largest association, specialty association. So everyone has to be part of it, and there is so many things happening here. So we have Oasis president here, we have Puducherry Orthopedic Association, TNOA president, so great dignitaries are there here. So I think so we should take their valuable advice, and learning never ends. So we also learn every day, so keep learning, and thank you.
Thank you, sir. I now request Dr. Krishna Gopal sir to kindly deliver a few words and share his valuable thoughts with us.
Good afternoon, everyone. Because it is past 12 and I don't want to be between the program and you. I wish the program a good success. One small information or request is, youngsters, please do not treat the images, treat the patients. Wish you all the best. Thank you.
Thank you so much, sir. I now request Dr. Shantamurthy sir to give the vote of thanks.
Good afternoon. So it is my proud privilege to propose the vote of thanks for this IAS One TNOA Joint Preservation Program 2026 being organized by the Indian Arthroscopy Society under the aegis of TNOA, Cholamandalam Arthro Society and POA. On behalf of the organizing committee, I extend my heartfelt gratitude to all the dignitaries on the dais, faculty members, delegates, sponsors and participants who have made today's academic program a grand success. First and foremost, I express my sincere thanks to the Honorable Chair Bearers, Dr. S.R. Sundarajan sir, President of TNOA and IAS and the Post Director, and being a mentor of so many of us, and Dr. Krishna Gopal sir, President of Oasis, Dr. Vijay Raghavan sir, President of POA, Dr. Prahlad sir from Madurai, Dr. S. Natarajan sir, Organizing Secretary of the today's program, and Dr. Manikandan sir, Organizing Secretary for the today's program, and Dr. Gopi Shankar sir from Jidmar. So it's a honor to be here before all of the dignitaries. I deeply indebted a special word of appreciation to all our esteemed national faculty members and faculties, speakers who shared their invaluable expertise through enlightening lectures, discussions, workshops going to be held and live surgical demonstrations. Most of the sessions covering ACL surgery, meniscal injuries, HTO, PCL reconstruction, multiligamentous knee injury and advanced arthroscopic techniques like all-inside technique were truly enriching and academically stimulating. I sincerely thank all the delegates and postgraduate students who are all gathered here showing their enthusiastic participation, active interaction and commitment to the learning. Your presence gave a lot of energy to this program. My heartfelt thanks also to the technical team, audiovisual team and the staff members, venue management for arranging this. We gratefully acknowledge Arthrex Avena Medical for their valuable support in promoting arthroscopy education and surgical training. So I thank once again to everyone. Thank you.
Thank you, sir. We now move on to the next session on meniscus. now call upon stage Dr. Satish Kumar sir to talk about types of meniscal tears and its management, as Dr. Kumareshwaran sir is unavailable due to unforeseen circumstances.
I am presenting this talk on behalf of Dr. Kumaresh, who could not come today due to a personal emergency. So the topic is meniscal tears, types and repair techniques. So we all know that meniscus is a very common knee injury, and historically meniscectomy was the only described procedure in the initial literature, but slowly the trend has moved towards repair. So what is the role of meniscus? It has a very important role in knee joint. It does load sharing, does shock absorbers, secondary stabilizers to knee, and proprioception and lubrication. So now recent article in 2013 has found out that the number of meniscal repairs are doubled in past 5 years. That is because of the improvement in the techniques of meniscal repair and improvement in the implants that are being used for meniscal repair. So they found out that there was a systematic literature where repair was done for and repair and outcome was compared at greater than 5 years. So they found out that repair technique does not matter. Most of the patients, no matter the repair technique, have very good outcomes. Where does the controversy come? The controversy comes where which tears has to be repaired. How do you assess post-repair how your repair has healed? What is the effect of damage to the ACL? So what is the clinical outcome? So these are the grey zones that need to be addressed in the future. So this is the anatomical structure. We know that we have medial meniscus and lateral meniscus. So it helps in taking up the joint load and does a shock absorbing activity. So we all know that blood supply arises from lateral, middle and medial geniculate arteries, and it forms a capillary plexus, enters the meniscus through the red zone. We all know that the richest blood supply is in the red zone, and red-white zone has relatively less blood supply, and white-white zone has almost nil blood supply. So the most consistent blood supply occurs at the anterior and posterior horns. And we need to know the zones of repair so that we know which repairs work well and which patterns can be repaired. So as I said before, there is a red zone, there is a red-white zone and red white zone. So 0, 1, that is the meniscocapsule zone. 0, 1, 2 have good vascularity, 3 does not have vascularity. So what are the tear patterns? We know that there are several tear patterns like longitudinal tear, radial tear, horizontal tear, oblique tear and complex tear. So most of the vertical tears, coming to the vertical tears, we know that vertical tears one of the better tears which have good results. Mostly it can be repaired, and sometimes it can be a bucket handle, and sometimes in unfortunate situation where we can't repair it, a resection would mean to a subtotal excision. So that is why we need to try to repair this tear as much as possible rather than resecting. And then we have radial tear. So radial tear is one of the most complex and difficult tears to treat. So what happens is there are incomplete tears and complete tears. There are two types. So the cadaveric studies have shown that repairing a radial tear has improved the tibio-femoral contact pressures, but the repair, no matter how good, still provide inferior outcomes to an intact meniscus. So this is one tear where despite all your good effort, the patient may not have a very excellent outcome or an outcome that we have expected out of vertical tears which have very good outcomes. Then coming to the horizontal tears are usually part of degenerative process. This is most commonly found in middle-aged population and elderly population. And since it is degenerative, the best method of treatment for this tears is meniscectomy, that is partial meniscectomy. So horizontal tear usually has a superior flap and an inferior flap. So taking out any one flap usually stabilizes the meniscus and gives good results. So then coming to the extent of tear, so there is a series of Ruckman et al. Series of 198 repairs that extended into the avascular zone. So they found out that 80% were clinically successful with 20% requiring re-operation in 42 months. So they are saying that currently now they are saying that there is a good results in white zone also. But however, this is a very short-term follow-up, and there is a even 20% means that this is a very high rate of resurgery. So the better advice is for white zone, better go for resection. And then when meniscus is associated with ACL injury, they have found out that meniscal repairs do very well because in ACL, when we drill the tunnels, the knee joint has a lot of blood in the joint, and which helps in good healing rate. So whenever there is a meniscal injury with ACL injury, always try to repair the meniscus because they usually have very good outcomes. So what are some contraindications for not doing repair? As I said before, white zone is a contraindication, and good factors that are associated with repair is younger patient, lesser BMI, no significant comorbidities. And one important thing is patient should be ready to do rehab, because in rehab, meniscal repair, the rehab is going to be slow and the recovery is going to be slow. The patient has to be mentally prepared and fully compliant to the rehab regimen. And red and red white we told has good results, less than 3 months old injury, and when it is associated with ACL reconstruction and it's a reducible tear without excess tension, so there we have good results. So rehab regime, again, it depends all upon the meniscal tear pattern, location, repair technique, and patient's compliance. So it is a very broad zone of rehab regimen. It has to be customized according to the patient needs, as said before in the first point. So these are the things that we need to look into, and we have to do the rehab regimen. So meniscal healing usually takes a lot of time, around 4 to 6 months. So the common consensus is that avoiding impact loading and deep knee flexion in early rehab always helps in good recovery of the meniscal repair. So again, as said before, the factors that are associated with better results are younger patient age, lower BMI, and obviously the surgical volume of the surgeon is also an important factor, and fellowship training has shown to be correlated with good results of meniscal repair. Coming to partial meniscectomy, so very limited data is there to compare partial meniscectomy with repair, but whatever data is available, that is saying that partial meniscectomy do well with short-term outcomes, but in high demand individuals like athletes, only 50% of them go back to sports, and repair category has definitely much bigger advantage in that group. 96 people go back to sports. So in meniscectomy, what are the predictors of positive result? Less than 40 years, normal alignment, minimal arthritis, single fragment tear. These factors have good positive results. Meniscectomy still has some relevance in these kind of situations where we are not able to help repair the meniscus. If these factors are there, the patient will do well with meniscectomy also. So the goal is to debride the tear, leave a stable rim. Preservation is ideal, that is not to resect too much, and the patient has a good outcome at 5 years. So to conclude, meniscal repairs are favored in recent years because of increasing awareness of importance of meniscal repair. All the data is now suggesting that repair is always better than meniscectomy. So meniscal repair, if the patient is active individual, that has to be the preference. The current literature is also pushing that we have to do even in white zone However, that may not be agreed upon by many people. So you have to take that point with a pinch of salt. And patient should be counseled for a high rate of reoperation. There is definitely a chance that your repair may not work and he may need a surgery. You need to not say a high rate of reoperation, but there is a possibility of reoperation. You have to tell to the patient. And again, the outcome all depends upon variability of the tear characters, patient factors, and rehab regimens. Thank you.
Thank you, sir. I now call upon stage Dr. Arun Prashant sir to talk about meniscal root repairs.
I thank the organizing committee for giving this opportunity. My talk is on about meniscal root tears. The meniscal roots, they refer to the point where the meniscal is directly attached to the underlying bone. That is the tibia. It gets attached both anteriorly as well as posteriorly, in which the posterior are the most common sites of the root tear. How to define root tear is either it gets avulsed from the bone or it is within 10 mm. There is a complete radial tear. Then it is defined as a root tear. This accounts for around 20% of the meniscal tears, in which the medial posterior roots are mostly degenerative type because they are very fixed to the bone, whereas the lateral roots are mostly traumatic type because it is comparatively mobile than the medial roots. What happens is, in a normal knee, when the knee is loaded, the compression from the femur is transmitted along the tibia through the meniscus. This meniscus converts the compression into circumferential hoop stress, which is then passed on to the roots. So this is how the load is being transmitted. Whereas when the root is being, when there is a root tear, the meniscus, once it gets the compression, it becomes extruded. So there is no circumferential hoop stress is formed. So what this leads to is decrease in the amount of contact area, as well as the contact pressure is going to get increased, which leads to what is the early degenerative changes. How these patients present is mostly in the traumatic type of tear. It's going to be a middle-aged females. Suddenly, while during the knee flexion activity, they hear an acute pop sound, following which there is a knee pain. Mostly they don't have any previous knee complaints, and this knee pain is going to get exaggerated by any knee flexion activities. Sometimes in a degenerative type of tear, there may be a knee pain for around 2 to 6 months duration, and slowly with a very small activity while getting up also they are going to face the same issue. How to evaluate this? First we take a radiograph. Short knee radiographs are just to see whether what is the any pre-existing osteoarthritic changes, and mainly to note the KL grade of the OA. Then MRI is literally helps us to see whether there is a root tear or not. In a coronal MRI, what we are going to see is if there is a root tear, there is going to be a hyperintensity between the insertion root as well as the main body of meniscus. This hyperintensity, it is called as the truncation sign. And once the meniscus is torn, this compression is going to cause meniscus extrusion, which means beyond the limits of this tibial margin, this meniscus body is pushed out. This is the meniscus extrusion. These two are what we are expecting in the coronal MRI. This extrusion should be more than 3 mm. Even in horizontal tears, we are going to see this extrusion. If it is more than 3 mm, it is more suggestive of a root tear. In a sagittal MRI, we will be able to see both the horns of the meniscus, both the anterior and the posterior horn. But when we are going towards the midline, if there is a root tear, only one of the anterior horn is visible, the posterior horn disappears. This is known as the ghost sign. Regarding medial meniscus root test, Laparade has classified the root test and given about 5 types. It's more about the morphology, which has more incidence and what is the outcome. Regarding lateral meniscus root test, it's Forkel's classification. It is mostly associated with ACL injuries. Here, along with the type of tear, he has described what type of repair works good for these patients. We have to, apart from the short knee X-rays and the MRI, we need to take an alignment X-ray just to see how much is the varus angle or the alignment. Why this is important, we will just see it in the following slides. In root test, the management include non-surgical management, mainly if the patient is unfit for surgery or doesn't meet the selection criteria. And partial meniscectomy only when the conservative measures, even with that the pain is being present, and since the patient has mechanical symptoms like locking or severe pain, then it can be done with partial meniscectomy. Then finally is root repair. Who is an ideal patient for root repair? First, the BMI should be less than 30 kilograms per meter square, or BMI is less than 30, and the mechanical varus or the femorotibial angle less than 5 degrees, and the Kellgren-Lawrence grade is between 1 and 2, and the duration between the injury and the surgery is less than 6 months, and the exclusion is less than 6 mm. Regarding the techniques of repair, there are 2 techniques. One is transtibial suture pull-out technique, and second is the suture anchor fixation technique. What we routinely do is a transtibial suture pull-out technique, in which first the root tear is identified, then as well as the grade of the cartilage changes, ICRS grade, is also noted in the medial compartment. Second thing, we have to go for the attachment site at the tibia. Using a femur drill guide, root guide, we are going to make a drill hole, as well as then we can pass the shuttle suture along the tibial tunnel and take it and park it at the anterolateral portal. Then using a knee scorpion, we are going to take a bite, cinch bite along the meniscus. We are taking 2 bites, and then we are shuttling it through the shuttle wire into the tibial tunnel, and we are finally going to attach it to the anteromedial cortex of the tibia. This is after the final fixation, where it's fully dunked into the tibial tunnel. So this is the routine rehab protocol. For the first 6 weeks, we do toe touch weight bearing, and knee ROM is restricted till 90 degrees. Beyond 6 weeks, there will be full weight bearing and progressive ROM, and strengthening exercises after 3 months, and complete knee flexion like squatting and cross leg sitting is avoided for 6 months duration. Regarding literature, when we see what is the outcome of this procedure along the prognostic factors, this paper shows the 5 to 10 years follow-up of the posterior root repairs, in which 91 patients were evaluated, and out of which only 1 patient had TKR at 4 years follow-up, and remaining 3 patients had lower Lysome score at 8 to 9 years follow-up. They have even extrapolated the 8 years follow-up. They are 92% of survival of the meniscus and the knee. They were able to save the knee. This paper compares the association between body mass index and the root repairs, in which they have found that body mass index of more than 35, it is associated with high amount of repeat surgery, mainly arthroplasty and clinical osteoarthritis symptoms. Here, along with the root repair, they have added a high tibial osteotomy if the varus degree is more than 4 degrees. Because while unloading the medial aspect of the knee, the root repair healing rate is more, as well as the amount of pain resolution is more if there is a varus. Along with that, they have found BMI of more than 30 itself is an increase, has the high risk of root tear. Here, between the duration since injury and the surgical timing, they have compared with the clinical outcome scores, in which they have found if the duration is less than 6 months, the patient has better patient-related outcome scores. But however, if you do more than 6 months also, the outcome score is better than a root repair than without doing a root repair. Then this paper, again, it tells about when we use a centralization stitch. Centralization is nothing but when the meniscus is very much extruded, we bring it back into the joint space. For that, we use a suture anchor in the mid tibia region, and then we tie it with the sutures so that it helps in formation of that hook stress again, hopefully. And this is mainly indicated in elderly age group where there is a chronic symptoms and the exclusion is more than 6 mm. So it's a very silent disease, so we must be highly suspicious of this to diagnose it, and an ideal patient selection is very important, and transtibial suture pull-out technique yields very good outcomes. Thank you.
Thank you, Arun sir. Your detailed explanation of the biomechanics, diagnosis and management principles provided us valuable insight into this important and often overlooked injury. I now call upon stage Dr. Satish Kumar sir to talk on discoid meniscus and bucket handle tears.
So I'll be talking on discoid meniscus and bucket handle tear. So first we'll start with discoid meniscus. So what is discoid meniscus? We all know that it is a congenital variant where the meniscus, which is usually C-shaped, is not present here and it looks like a big disc. And commonly it happens in lateral meniscus and there is a higher tear risk. So the incidence rate is 1 to 5%, higher in Asian population. And bilateral can happen up to 20% of the patients, and usually younger, it is involves the symptoms are in younger patients because since it's a congenital anomaly. So the classification, we have 3 classifications for this. One is complete, incomplete and the Risberg variant. So in the complete we have the entire discoid meniscus is covering the condyle. Incomplete, it is almost like 75-80% covering. Risberg variant is the slightly more difficult variant to treat, where there is absolutely no attachment of the meniscus from anterior to posterior. So why is discoid meniscus problematic? Because the tissue composition is not normal. It is not like a normal meniscus. There is lot of mucoid degeneration, and histologically the collagen fibers are not organized and very sparse in nature. So the structural integrity is weaker. And reduced vascularity, we all know only red zone has the proper blood supply, and since it's a discoid, it's almost like a huge area of white zone which has no blood supply. And biomechanically, since because of missing attachments, it is a very unstable meniscus which will create a problem to the patient at some point. So like any other meniscus tear, the symptomatic discoid meniscus happens when a patient has sudden onset of tear. The patient may be normal for 15 years, 20 years, 25 years, but suddenly the patient will have pain. That is because of the inherent instability of the meniscus, the patient must have developed a tear. And when the tear is developed, it's a classical presentation just like any other meniscus patient. The patient will have pain, clicking, locking, effusion and reduced range of motion. So this is a classical presentation of a meniscal injury. And examination, again the patient will have a classical lateral joint line tenderness, McMurray will be positive, and there will be a snapping knee because it is getting stuck between the femur and tibia. So there will be a snapping sound which you can be audibly heard, or if you keep your finger you can feel it, the snapping sensation. So how to pick it up on MRI? MRI, the main giveaway for this discoid meniscus is that in sagittal section, if you see the meniscus, if the meniscus entirely you are able to visualize from anterior horn to posterior horn, full thickness in at least 3 sections. Usually it's not visible more than 2 sections. If it is seen in 3 or 4 sections, that means you are looking at a discoid meniscus. And there will be when the patient is symptomatic, there will be obviously some tear. So the signal change of tear also will be seen in the MRI. So treatment, the patient, this is observed if the patient is asymptomatic. However, the patient will not come to you when the patient is asymptomatic. It may be incidental finding where taking MRI for some other reason. The patient is coming with you, he usually comes with symptoms, and when it is symptomatic, obviously the patient is going to need surgery. So management, how do you manage? So the 3 options. First is the discoid meniscus, you have to bring it back to its normal shape. You have to bring it to the C shape. So for that we do something called saucerization. where we remove the excess meniscal tissue, and because it is associated with meniscal tear, it will need meniscal repair. And in Risberg type of meniscus, there will be nothing to hold the meniscus inside. So you have to stabilize the meniscus by using your repair techniques. So you can use the standard portals. So the key is not to saucerize too much. It's a very classical dilemma where you feel like you have left too much. You go in, take out too much, then you feel like you have taken out too much. It is an irreversible, you can't bring it back. So you have to be very carefully seeing that some amount of rim is preserved, and stability is very important. Just saucerization is not enough. Often there is a tear inside which may get missed. So check for stability, and if it is unstable, you have to fix it. So main key is avoiding over resection, and check for posterior stability, because that is where the tear is usually found. And wherever possible, definitely you have to go for repair, because here if you do meniscectomy, it's going to be a problem for the patient in future. So it's a case history of a patient with a 21-year-old female. She had 4 years of knee pain, on and off locking symptoms, on and off swelling. Was managed by native treatment and not getting treated with orthopedician. So presented with these symptoms. So it was a classical Risberg type of meniscus. You can see this is how a normal meniscus looks in first image. So in the second image, you can see the Risberg type. There is no attachment found from anterior horn to posterior horn. So this kind of tear is very difficult. You need to stabilize the tear, and it's not going to be easy. So I would like to have opinion of Sasi sir and Prahlad sir for this case. I had managed in a certain way. So what I found was it was a Risberg type. You can see that the meniscus was absolutely going into the joint without any stability. So I had to use initially a traction stitch so that I can pull it, and then I had to use a suture anchor technique. So I had put a suture anchor in the tibia, then double loaded suture anchor, then I had taken bite through the meniscus, and when I started putting knots, it has begun to come back and become stabilized. So used 2 bites, sutured it, made sure that the knot is on the capsule side, not on the meniscal side, and then I started saucerization. So after doing some saucerization with our hand instruments, I found out that the C shape of the meniscus was relatively restored, and once after doing that, I began probing the posterior part, which will come up now. So after probing that, I found that there is no attachment posteriorly also. It was grossly unstable. So I had to stabilize that part with all inside repair technique. And again, I had to put one more suture anchor to stabilize the anterior horn. So the final repair looks something like this. So decent amount of tissue was saucerized and stability provided with all inside in the posterior part. In the body and anterior part, I had to use 2 suture anchors and look relatively stable. Sir, your opinion, sir?
That's one of the way you do, Satish. Last week we had a similar case, and this we come very frequently. We come, and some of the time we miss this because you see that entire thing is there, and if you start taking it out, then it becomes a very unstable. So
yes.
You really don't know like how much to take out.
Correct.
So it is the way we have to do. Suppose if you don't have an anchor, if you have not planned an anchor, no, the simple thing is you just take outside in.
Outside.
Right. And you can just pull the meniscus here, but again in that situation you will be not able to bite the anterior thick portion.
Yes, sir.
So once you secure the posterior, and then you can otherwise you can take the bites through the meniscus so that you can keep some ring to trim.
Yes, sir.
This is one of the good technique you can do.
Thank you, sir. Sasi, sir.
I think principally the patient has been managed very, very well.
Thank you, sir.
What we want to achieve is stability of the repair and also trying to achieve the shape of the meniscus. I did really have a similar patient, around 17-year-old man, boy. I even discussed with Dr. Prahlad. The MRI was reported as an absent anterior meniscus and basically and very highly thickened posterior meniscus or something like that. Basically, it was a large discoid bucket handle kind of there that is flipped to the back. But actually, there was a little bit of attachment anteriorly, so that was a good thing for me. And I managed something like that. And as Dr. Prahlad said, suggested, I also used outside-in stitches in order to reduce the meniscus. Yes, anchor is also a good option. Finally, the principle is the same. You want to reduce the meniscus and repair it anatomically, and then try to create a C shape for the meniscus. I think they do very well. As long as you have removed you have done a authorization, the peripheral part of the meniscus is going to be quite vascular, and they are going to do very well.
Thank you, sir. So outcomes are usually generally good when you do the repair and do proper authorization. So key is not to over resect. So complications, again, definitely the wristband type is something like they don't have the attachments by birth. So you are just stabilizing it by putting your bites. The patient again goes back for some high functional demand activities like sports. There is a definite risk of re-tear. So counseling to the patient, I think, should be very guarded that this may need a resurgery in the future if you go for high demand activities. And definitely the other routine rehab related stiffness or some other complications. So early diagnosis, preserving the meniscus, stabilizing the meniscus and avoiding the resection. So this is the summary of the entire thing. So coming to the bucket handle tear. So we have what is bucket handle tear? It's a vertical longitudinal tear with a displaced fragment in intercondylar lodge. So common in young active individuals, most common in medial meniscus. And it is, as we all know, it is frequently associated with ACL injuries. So mechanism of injury is just like typical routine ACL injury, twisting injury, pivoting ports. So rotational load on flex knee causes bucket handle tear. So clinical features, I'm not going into that again, the same classical features that you get. Joint line tenderness, again the same thing, positive McMurray and restricted or like any other meniscus tear. One key thing under anesthesia that you can that will help you suspect is negative pivot shift. So because the bucket handle is flipped inside the notch, when you do pivot shift, you may not feel the classical pivot shift that you get when you are doing it with the ACL tear. That is where I am saying. So that means you should have a clue that this is going to be a flipped bucket handle and it may need repair or resection. So we all know that peripheral vascular zone heals better. So meniscal preservation is the best way to go for bucket handle tear. MRI findings, we have a double PCL sign, absent bow tie sign, displaced fragment. You can see the fragment in the notch, flipped meniscus. So indications, definitely lock, near mechanical symptoms are there. You need to go for surgery. Treatment options, meniscal repair is definitely the ideal way to go. But this is not possible in all cases. In chronic tears, irreducible tears, you may need to go for a partial meniscectomy. So the key for repair is you have to reduce the meniscus. So you need to use a probe or a trocar, something to slowly help it reduce the displaced fragment back to its place. And sometimes you will feel like you are not able to reduce it, or if you are reducing it is coming back, especially in chronic cases like 2-year, 3-year-old injury. There, unfortunately, we may have to go for a meniscectomy. It is indicative of chronic tear. Also, you have to assess the quality of the tissue. Chronic tears are very bad fraying. You can get the feeling that this may not heal, and those patients may need meniscectomy. So repair techniques, we have inside out and all inside. Inside out is you can use it from the mainly in the body of the meniscus. Outside in for anterior horn, anterior body. All inside is very easy to do especially in the posterior part of the meniscus where you can't do inside out. So inside out, what is the advantage? It is cost effective, but however it requires some time. It's not and some more skill. You need some patience to do it, and it is you can do it in the body of the meniscus, but cannot be done behind the near the posterior because we have the vascular structures. And all inside, it is a minimally invasive technique, but however it doesn't come easily. It's more expensive, technically simpler, faster, and especially in posterior horn, we don't have any other option. We have to go for all inside. So we need to freshen the edges of the meniscus, maintain the reduction, use adequate sutures to stabilize the meniscus. And again, when you are going for meniscectomy, don't try to over resect. and if the reduction is poor, then the results may not be great even after the repair. So I'm not going too much into the surgical techniques. This is just a demonstration of a bucket handle tear. So this is a classical bucket handle tear. This is how it looks. It's very unstable from the anterior part to the posterior horn. And this is post repair, repaired with all inside meniscus technique. So you can see that they tend to be very stable after the repair. So meniscectomy, is there any role for meniscectomy? Definitely in chronic irreducible tears, we need to do that. One key point for doing meniscectomy is take one accessory portal, take a grasper inside for holding that fragment, so that from the medial portal you can start cutting it with your duckbill instrument. So that is one useful tip. So rehab, when you do repair, protect the weight bearing for 4 to 6 weeks, range of motion up to 90 for first 6 weeks. Return to sports, it's not that early. It's better to wait. It's isolated meniscal repair, you can follow this, but if it is the ACL, you need to follow that standard duration of 9 to 12 months. So complications, definitely everything comes at a small amount of complication risk. So there is a risk that your repair may fail. You may go for a re-tear, and rehab is not done properly, it may go for stiffness. And while during the repair, definitely if you are using, risking too much all inside in the posterior region, there is a risk of neurovascular injury. So the take-home message is preserve the meniscus wherever possible, because this is one tear which does very well with repair. And when it is not possible, at least take out as much as is needed, and make it not too much over resection during meniscectomy. Thank you.
Thank you, sir. That was an excellent session on discoid meniscus and bucket handle tears of the meniscus. This has provided us with valuable practical insight on these important meniscal tears and pathologies. I now call upon stage Dr. Prahlad Kumar Singhi, sir, to talk about building a new meniscus, its indications and technique.
Good afternoon again. So I think we had an excellent session on meniscus. We have seen the anatomy of meniscus, and we have seen the various types of tears and how to deal with these kind of tears. So see, we are in a country where we don't have certain access to certain things, and also this necessity has made us to do certain things, and we have done our own procedures also. So I'd like to share you a few of my insights on building a meniscus using an autograft. So this is not for the first time I have done this. This procedure has been done. Several literatures are there. There is scattered literatures. So we all have been told about the meniscus, like it is an vestigial organ. The Smiley told it, you can take it out if there is if it is torn. But now in 2025, we all feel that meniscus is very important. We have to save meniscus whenever possible, whatever possible extent. So the anatomy has been beautifully covered by our previous speakers, Satish and Arun. So it is like majority of the meniscus is made up of water, and then we have the type 1 and type 3 collagen. The arrangement of these fibers makes it unique. So practically it is not possible to reconstruct or recreate a meniscus, and so whatever we are able to do is it is practically not possible to bring a meniscus back. So what happens when the meniscus is lost? So we have seen that it progresses to arthritis, and it goes very rapid progression if it is not addressed in an young individual. So what are the treatment options we have left when there is no meniscus in an individual? So we have the meniscus allograft transplant, we have the scaffolds, and then we have autograft. So when to do it? It is again the young individuals less than 50 years, or the patient who have undergone subtotal or total meniscectomy, but they have early KL grade of degeneration. So advanced grade of degeneration, it's better to avoid doing a reconstruction procedure. So meniscus allograft, again there are several types. The fresh allograft are the one which are fresh frozen or the available one, but it is very difficult to procure these allograft, and it has its own pros and cons. So you have to get a perfect sized matched graft. Sometimes you can have undersized graft or oversized graft. Or also to fix this graft, there are bone plug technique, or you have the soft tissue technique. So you have to understand the various techniques of fixing this autograft. It has its own advantages and disadvantages. So there is no still clear consensus on techniques and long-term follow-up availability, and also the cost and immunogenicity is again a concern in allograft. Coming to scaffolds, again there is a similar concern in scaffolds. We don't really have any implant in our country presently. So it is again experimental. So though there are several varieties of scaffolds being described in the literature, we don't have access for these scaffolds. So do we have a solution for this kind of concern when you have a patient with a loss of complete meniscus in an young individual? We performed a study here at Preeti hospitals with appropriate consent, and so why we select autograft? Because it is easily available, and there is not much donor site morbidity, and there are a lot of advantages. There is no risk of immunogenicity or disease transmission, and also you don't have to get an accurate size of the graft before thing. And we have seen from our cruciate experience that it gets ligamentized. So the 3 surgical steps we will try to describe, it is like a fracture fixation. So any time when we do fracture fixation, we want the better opposition, stability and healing. So the 3 things is you create the bed properly, you do a proper rasping and bleeding environment, and then you achieve a better fixation by at least having 12 to 14 stitches around the meniscus. We do a root fixation, so we create an anterior root and posterior root, so that your graft is also fixed to has an aperture fixation. So this is one case example. A young gentleman who was operated twice already for the bucket handle repair. He came to the 3rd time to us with the bucket handle again recurrent. So I suggested him either MAT or allograft transplant or the autograft. So he accepted autograft. So we used his peroneus here. So we railroad the peroneus graft through the anterior and posterior tunnels, and then we fixed using multiple all-inside devices and outside-in devices, and we got a stable fixation. So this is the new meniscus which we have created for him, and this is almost now 1.5 year follow-up. So you can see this is the meniscus which is still there, though in the initial stages it looked bright signal, but we have to do a relook to see how he does. So this is how we did this NCHAP. This is almost now 1.5 year follow-up. He is back to his work. So far no complaints, and we have done 5 cases, 6 cases so far. So we have done it couple of partial meniscectomy cases where there was partial loss of defect. For example, in this case there was a defect of 3 to 4 centimeters. So we just made tunnels and at the either ends, and we fixed the graft with the whatever techniques of fixation, and the most important is to achieve the stable fixation. So the standard rehab protocol we follow, and these are the various literatures where initially they have used quad to reconstruct this kind of graft, and this is by Amit Joshi from Nepal. He has done several cases, so I had discussion with him also. So we will see there are pros and cons. So we are just about to publish this paper. We are preparing for the publication, and though allograft is gold standard, it is expensive and availability is a concern. Tendon autograft can be a promising solution. So we still don't have much options. So we are just waiting for some long-term studies to come and give their experience. Thank you.
Thank you, Professor, for that insightful session on building a new meniscus. I now request our chairpersons to kindly give the memento to our guest speaker, Dr. Arun Prashant sir. Thank you, sir, for that wonderful session, and we will now break for lunch and resume the academic proceedings shortly thereafter.
₹152.
Good day everyone, welcome back after the lunch, and I'm sure I'm going to keep you awake. Thank you everyone again for this wonderful opportunity. Thank you the moderators for agreeing not to ask me too many questions. I'm Dr. Sasinda. I will be speaking about high tibial osteotomy, and I will try to cover with a few interesting cases after we go into the details of the principles of high tibial osteotomy. I'm Dr. Sasinda, Senior Consultant Arthroscopy Surgeon from SRM Global Hospital, Chennai. So, before we go ahead with a surgery like high tibial osteotomy, which is a deformity correction surgery, we need to understand the deformity that is present in the patient. The patient is not going to read Campbell and land to us. The patient is going to have a clinical disease, clinical condition, and we are supposed to identify all of them, and we cannot afford to identify only what we know. We need to know what needs to be known. We need to understand what is the frontal plane deformity of the patient, what is the sagittal plane deformity of the patient. Frontal plane deformity presents in the form of a varus deformity or a valgus deformity. Sagittal plane deformity we present as hyperextension or flexion deformity, and axial plane deformity is rotational deformity. Okay, but for convenience sake, we will stick ourselves to coronal plane, that is frontal plane deformity, in this discussion. In order to assess this both clinically and radiologically, the positioning of the patient is very, very important. You can't have a patient with leg in external rotation and try to assess the coronal plane deformity, or in other words, the varus valgus deformity of the patient. The position of the patient is very important. The patella should be facing forward when you are trying to identify these conditions. And in X-ray as well, especially when you are taking a scanogram, in order to identify or quantify the deformity, both the lower limbs have to be symmetrical and the patella should be facing forward. For example, this is a patient where a scanogram was done. This is my own patient. The patella is almost symmetrical and central, and they are facing forward, and this is definitely suitable for identifying and also quantifying the deformities or varus or valgus that is existing for the patient. And if there is a shortening, you should make sure you are compensating for the shortening. Otherwise, instead of you compensating for it, the pelvis is going to compensate and it is going to give you a false value. But if you see this patient was assessed by someone else, and patient came to me with a referral letter of high tibial osteotomy for the left knee. But if you see closely, the two lower limbs are not symmetrical. The left patella is facing outwards, the left lower limb is externally rotated, and there appears to be a varus deformity in the knee or a medial joint space reduction in the knee. And that is why the other surgeon had recommended high tibial osteotomy for the patient. She is 35 years old, but I didn't repeat the scanogram. Clinically, she didn't have a varus deformity, so I did not repeat the scanogram, but for confirming it with the patient, I did the weight bearing X-ray of both the knees with the patellae facing forward. Believe me, both are for the same patient. So the medial joint space, this is a weight bearing X-ray, medial joint space, there is absolutely no joint space reduction and there is no varus deformity, so no high tibial osteotomy for the patient. So assessment is very, very important. You can't just want to do high tibial osteotomy and do a wrong investigation for the patient. But then sometimes the wear in the knee can be slightly more posterior than anterior, so that can be identified only by a Rosenberg view, that is flexion, 30-degree flexion, 45-degree flexion X-ray. So that is how Rosenberg view is done, and if there is a unicompartmental joint space involvement in this view as well, then the patient is a good candidate for high tibial osteotomy. And now we need to understand certain axes and angles. The most important is MPTA, or in other words, MMPTA, medial patellar, medial proximal tibial angle. Okay, and LDFA is lateral distal femoral angle. In other words, this is proximal tibia, and you are calculating the angle on the medial side. So it is medial proximal tibial angle. We know the proximal tibia is in slight varus of around 3 to 4 degrees. So that is why this is not 90 degrees normally, this is 87 plus or minus 3 degrees. Similarly, the distal femur is in valgus, so that is why this angle is not 90 degrees, it is 87 plus or minus 3 degrees. So we need to understand this. So they have to be almost close to 90 degrees, or in other words, MPTA should be just less than 90 degrees and LDFA again should be just less than 90 degrees. And we need to understand the plumb line. Plumb line doesn't always fall, plumb line is the vertical line from the hip joint, center of the hip joint to the center of the ankle joint. It doesn't always fall on the center of the knee joint, that is in between the medial tibial spine and the lateral tibial spine. It lies slightly more medial. Fujisawa described it as lying at 62% of the knee joint starting from lateral aspect, but that is contested. We don't do 62% for high tibial osteotomy. The most important other angle that we need to understand is JLCA, joint line convergence angle. For example, this patient has a medial knee osteoarthritis and joint line convergence is there. That could be approximately around 3 degrees or 4 degrees. And this patient, the same patient after high tibial osteotomy has correction of joint line convergence. Why this is important is you can't just calculate the whole deformity and try to correct the whole deformity with your high tibial osteotomy. What you are trying to do with high tibial osteotomy is to shift the vector from the medial side to the lateral side. When you shift the vector, automatically the joint line convergence will correct. So that much of correction should be under-corrected. For example, the patient has a 15 degree varus deformity and the joint line convergence angle is around 4 degrees. You have to correct the patient by only about 11 degrees, not by 15 degrees, because otherwise you will be doing an overcorrection of 4 degrees. So that is also something that you have to calculate. Stress X-rays, yes, they are very important in order to check not for MCL rupture but for MCL laxity. For example, there is a varus deformity and there is no opening with stress. That means the MCL is very tight, you have to release the MCL. If you don't release the MCL and you just do a high tibial osteotomy, you will be overstuffing the medial side and you can actually increase the pain for the patient rather than relieve the pain for the patient. Double level osteotomy, this is the reason you need to calculate both MPTA and LDFA. If both are affected, you can't try to correct both deformities only by your MPTA. That will result in an oblique joint line. And obliquity of the joint line of more than 4 degrees is not normally accepted or tolerated by the patient. So if there is double level deformity, which is calculated by LDFA and MPTA, you have to correct both of them, not only by MPTA, or in other words HTO, because you attended my presentation today. So all angles ready, JLCA ready. And then how much is too much or how much correction is needed. This is where Fujisawa point comes into picture. The plumb line doesn't always fall on the midline. It falls slightly more medial to it. Fujisawa wanted to correct it to 62.5% starting from the medial side. But that can be acceptable for severe varus deformity, but not for the younger patients where you want to do high tibial osteotomy, because you don't want to unnecessarily overload the lateral side too much. And then where you want to do the osteotomy, usually on the waist, pointing towards the tip of the head of the fibula, not the head of the fibula. Head of the fibula is a larger area. This is the head of the fibula. If you are aiming at the head of the fibula, your osteotomy will be somewhere here and will be too low. You have to aim toward the tip of the head of the fibula. Positioning supine with knee possibility of bending to 90 degrees and extending. Superficial MCL release is very important, because otherwise MCL could be very tight and you could be overstuffing the medial side. You need not release the MCL completely. You can just do a partial release, just like you do a partial release during total knee replacement. Skin incision, longitudinal incision, slightly more on the medial side, or an oblique incision. I like longitudinal incision. Osteotomy line from the waist towards the tip of the head of the fibula. I always do dual plane osteotomy because you don't want to risk
the possibility of avulsing the tibial tuberosity or the patellar tendon. So what happens is you have a horizontal osteotomy line and almost vertical osteotomy line, and that is your tibial tuberosity. The vertical osteotomy line exits the bone just proximal to the insertion of the tibial tuberosity. You can't have this vertical line too vertical, otherwise it will exit into the joint. You have to be very careful. You have to exit it just proximal to the tibial tuberosity so that you can correct the deformity without having to risk tibial tuberosity avulsion. The other reason why you want to do this is most of the patients have patella alta. Very few patients have patella baja. When you have patella alta, when you are opening this and the tibial tuberosity is attached to the distal fragment, then the tibial tuberosity moves down. So the patella alta also gets affected. So that's another reason why you want to do dual plane osteotomy rather than single plane osteotomy. Have I done single plane osteotomy? Yes, I have done, but you have to be a bit careful not to be aggressive with your saw in the location of the tibial tuberosity attachment. Tibial patellar tendon doesn't insert into a point onto the tibial tuberosity. It inserts into an area onto the tibial tuberosity. So if you are very careful, you can just go over it, but as much as possible, do a dual plane osteotomy. So that is how you usually aim toward the tip of the head of the fibula and use another parallel wire. Both the wires practically should not be visible as two wires in your CM. They should be visible as one wire. That means they are uniplanar, and then use a broad saw. The anterior wire will be where you want to have the junction of the vertical osteotomy and the horizontal osteotomy. The posterior, that is around 1.5 centimeter from the anterior surface of the tibia or the shin of the tibia, and the posterior wire is just anterior to the posterior cortex. So that's a broad osteotome that you use for the horizontal osteotomy, and you use a narrow osteotome for your vertical osteotomy. I don't like this osteotomy, this saw for my vertical osteotomy. I use a narrow saw. So, and you keep opening the medial side, and you also have the option of correcting the posterior tibial slope. Why? Why should you correct? If the patient has an anterior instability, then you try to reduce the slope, and if the patient has a posterior instability, you try to increase the slope. This can help in correcting the instability as well. So that's the osteotomy going ahead, and that is the vertical limb of the osteotomy. You use laminar spreaders to hold it temporarily after you have opened it. You have wedges, metal wedges, to also calculate the amount of opening that has been done. The usual calculation is the height of the opening. Each 1 millimeter is equivalent to 1 degree of correction, but that is not an absolute figure. That is just a crude picture. Okay, so you have the option of using a wire or an alignment rod in order to check from the hip to the ankle, but I have never been a big fan of this technique because there is too much subjectivity into consideration here. I go mostly by eyeballing. So, and then you finally use a fixation device of your choice, a plate on the medial side, in order to fix the osteotomy or fracture that you have created. Complications, mostly it is an uncomplicated surgery if you follow the principles. If you are aggressive on the anterior side, you can avert the tibial tuberosity. If you are too short-tempered, not to advance all the way laterally and start opening, you can extend the osteotomy into the joint. I will tell you what is too short-tempered. Okay, so when you are going ahead with the osteotomy here, the horizontal thickness of the bone should always be lesser than the vertical thickness of the bone. The osteotomy will progress toward the point of highest weakness or least strength, right? So if you have a horizontal intact bone that is larger than the vertical intact bone, the fracture is going to exit into the joint. So you always have to
be as close to the lateral cortex of the tibia as possible so that the osteotomy will extend into the lateral cortex, not into the joint line. So that is what was wrong here in this particular example. You have too much of bone laterally. Your osteotomy should have extended all the way here, then it would have opened laterally, not into the joint. So that is something to be looked out for. Case examples. This is a patient with failed ACL reconstruction since many years with varus deformity, young guy, around 40s, varus deformity of the left knee, failed ACL because it was done by it was done a long time back. He had a vertical ACL, the roof attachment of the ACL, severe medial osteoarthritis of the knee, too young for total knee replacement. Lateral side is not too good, but too young for knee replacement, so high tibial osteotomy is the option. High tibial osteotomy along with revision ACL reconstruction. What do I use for revision ACL reconstruction? I'm already trying to correct the slope also, reduce the slope also during my high tibial osteotomy, but I also add an ACL reconstruction for these patients after I have done the osteotomy and has temporarily stabilized it with the plate. I go ahead with a soft tissue reconstruction of the ACL, normally in the absence of arthritis, medial osteoarthritis. I use bone patella tendon bone graft for revision ACL reconstruction, but in the presence of high tibial osteotomy, I cannot have the bone patella tendon bone, and I do not want to have it sit from the other side. It is good enough because I have also tried to correct the slope of the patient. So I will use a soft tissue ACL reconstruction like a hamstring or peroneus or superficial quadriceps, and that will be used here. And I don't use interference screw in the proximal fragment here because it's already small. We don't want to blow out. I use a suspensory fixation on the proximal fragment as well. So this is another patient of revision ACL reconstruction, high tibial osteotomy, and revision is sometimes I use screws, and revision ACL reconstruction is soft tissue. So case number 3, high tibial osteotomy with ACLR with medial meniscus replacement. I'm trying to pick up my another slide. Okay, so Dr. Mani, I think I have some time, right? Yeah. So this 51-year male football coach. Previously he was a football player. Now he's a football coach with he has been having ACL tear, and he has undergone meniscectomy twice, like 10 years back, and he presents with a lot of pain on the medial side of the knee. Meniscectomy in 1993 and 1995, a lot of instability, not much of pivot shift, but a lot of instability. And varus deformity. So that was his X-ray. Lateral side is not perfect, but it's not very bad. Medial side is very bad. It doesn't have any meniscus on the medial side. It's absolutely taken away, eaten away. And the lateral side is relatively okay. And that was a scanogram, medial osteoarthritis, 7 degrees of varus deformity. So we plan, he doesn't have any meniscus on the medial side, so we plan for something like what Dr. Prahlad was discussing. There is high tibial osteotomy and replacement of the medial meniscus. Patient not too affordable, and this patient was operated like 4 years back, and that time we did not have allograft in India. Now Ceramics has provided allograft with DMRC. So we planned with peroneus tendon meniscus replacement on the medial side, plus high tibial osteotomy, plus ACL reconstruction. So that are the to the medial side, no meniscus, or only the periphery of the meniscus is there. That is the lateral side, relatively okay. That's the ACL tunnel, and this is the medial meniscus anterior root tunnel. So they are away from each other, they are not merging with each other. In this patient, I would definitely prefer to use a suspensory fixation for the ACL because I do not want to blow the tunnel wall of the ACL into the anterior horn of the medial meniscus. So both the tunnels are made. And then the posterior root tunnel is also made because we had to replace or reconstruct the whole of the medial meniscus. Hamstring tendon was prepared for the ACL. Peroneal graft was prepared for the meniscus replacement. Traction sutures were placed in the peroneal graft. High-tibial osteotomy was done. Fixation of the opening osteotomy was completed. That is the periphery of the meniscus. We had sutures ready for outside and traction sutures in the body region, and we had all inside sutures ready for the posterior aspect. And that is the graft going in, that is the peroneal tendon graft going in, and all inside stitches for the posterior aspect. This is the ACL, this is the peroneal tendon graft. This was supposed to be a video, unfortunately it's an image. So finally we had a peroneal tendon reconstruction along with high-tibial osteotomy along with the ACL reconstruction. And the patient is, this is a picture around 12 months after surgery, but the patient is right now 4 years after surgery and he has gone back to playing football and coaching football. So that is case number 3. Case number 4 is, I would like to discuss a patient, an interesting patient where posterior tibial slope correction was very, very important. Okay, this is a young lady who presented to me. This around a 41-year young lady presented to me. She had surgery to the knee around 15 years back. She said it was an ACL avulsion injury which was fixed with screws. But she presents with severe pain in the knee. She walks with severe flexion deformity, around 30 degrees of flexion deformity, too much pain. There are screws inside for the ACL, and there is a lot of medial osteoarthritis. This is a weight-bearing X-ray. The medial side is completely bone on bone. But she is just 41. 41, not a good candidate for knee replacement. Thus, MRI shows meniscus extrusion, medial knee osteoarthritis. MRI has a lot of artifacts because of the screws that are present there. ACL and TCL not absolutely studyable because clinically she had both anterior laxity and posterior laxity, severe grade 3 anterior laxity and posterior laxity. But PCL, you can see the PCL here, the PCL appears to be intact. But she has a lot of posterior laxity, so I was trying to take stress X-rays, trying to see whether there is actual posterior instability, but I was not very successful. The X-rays were not great. Then we just noticed that in the lateral view, the tibial slope is reversed or nullified. She doesn't have posterior tibial slope, so we had a possibility of absence of posterior tibial slope leading to posterior instability without actual PCL tear. So we went in, removed the implant, and then we checked for the PCL. Arthroscopically, PCL was intact. We went ahead with an high tibial osteotomy. This is before high tubal osteotomy and fixation. She has posterior instability. That's the posterior instability, that's the anterior instability. Posterior, anterior. And that's in 30-degree flexion, posterior, anterior, gross instability. And then we proceeded on to arthroscopy, lot of medial osteoarthritis, lot of loose bodies, everything was removed. Loose body removal, too many loose bodies. And then implant removal. Implant fixation was done in open surgery, so we had a little bit of time trying to remove the implant arthroscopically itself. And we went ahead with high tubal osteotomy. This time the hinge of the high tubal osteotomy was not lateral, but it was posterolateral because we wanted to create the posterior tuberous globe, so we wanted to open both anteriorly and medially. This was a dual plane osteotomy, trying to open anteriorly and medially, and after stabilization with the osteotomes, there is absolutely no posterior drawer, only anterior drawer. No posterior drawer, only anterior drawer. So we went ahead with fixation with anterior opening and medial opening and ACL reconstruction. The patient also had lateral meniscus posterior root tear, which was also repaired during the same sitting. The joint was not very bad. The lateral meniscus posterior root was torn. We repaired it, so I'm still happy that the lateral side will bear the weight appropriately. She is 1 year post-operative status and she is doing really well. So that's the lateral meniscus posterior root repair. So that the implantology work there, high tubal osteotomy and ACL reconstruction. I said suspensory fixation for ACL reconstruction for patients undergoing high tubal osteotomy. So that's a button sitting there for the ACL and root repair with suspensory fixation as well. I think the root was repaired to the same button as the ACL. Okay, so do I have time for one more case? Okay, so that's the patient with high tubal osteotomy with ACL reconstruction, posterior tuberous globe correction and lateral meniscus root repair. That's what we discussed now. And then high tubal osteotomy with tibial tuberosity osteotomy. Rare combination, not usually recommended. Young lady again. She presented with patellofemoral pain, not with medial joint line pain. She presents with anterior knee pain, very painful, limping, not able to walk, but X-rays I don't like, meaning there was medial joint face reduction as well. There was, in other words, there was varus deformity as well and a little bit of subluxation, but she was not presenting with medial knee pain. She had anterior tibial pain, but I was not very happy with doing only a tibial to prostate transfer. There was a lot of arthritis. She was not a candidate for salvage or cartilage reconstruction for the patellofemoral joint. Otherwise, I would have preferred OATS, osteoarticular transfer surgery for patella and or the trochlea. But she had a lot of arthritis on the patellofemoral joint, so she was a candidate for tibial tuberosity osteotomy. But I wanted to open the medial side as well because she had a bit of varus deformity on the medial side. So we went ahead with a combination of high tubal osteotomy and tibial tuberosity osteotomy. Certain lessons to learn in the hard way because we are opening, because we are osteotomizing the tibial tuberosity. There was a bit of soft tissue loss on the lateral side as well. You cannot osteotomize or mobilize the tibial tuberosity without releasing a bit of tissue on the lateral side. And the lateral side tissue is required for the hinge of medial opening wedge osteotomy. So the lateral side started opening up. So there was no soft tissue hinge on the lateral side. So I had to create a metal hinge on the lateral side. That was the extra plate on the lateral side. So she underwent high tubal osteotomy, patella tendon osteotomy, tibial tuberosity osteotomy, and lateral support as well. She is, that's the post-operative X-rays. She is 6 months post-operative status now. She is walking well. Her range of motion is, flexion is around 120 degrees. I am not asking her to push further because pushing further will lower the patellofemoral joint further and cause further pain. So she is happy, no flexion deformity, flexion to 120 degrees, walking without pain. So yeah, I think too much for everyone including me. So tips and tricks. That's about it. If I have some.
Yes, Dr. Sasi.
Yeah, thank you. Thank you for saving me.
So, when you're planning for a HTO, do you always check for the integrity of the ACL and meniscus? And if the patient has had a previous meniscectomy, either a full meniscectomy or a partial meniscectomy, does that affect your modality of management?
Sorry.
So when you're planning for a HTO, do we need to check for the integrity of the ACL and the meniscus, the status of the meniscus? And if the patient has had a complete meniscectomy before, like the first case you presented, will that affect your management?
Yeah. Good question. I don't completely validate my meniscus replacement surgery in this particular patient. We need to understand that as per biomechanical studies and outcome studies that have been published, it's not absolutely required to repair the medial side when you are doing a high tibial osteotomy. Okay? But I do try to take it with a pinch of salt because evidence is created by you and me. We still cannot accept everything. If it is a very young patient and if the patient is able to afford for the meniscus repair on the medial side, young patient first, then affordability of medial meniscus repair, I do high tibial osteotomy with medial meniscus repair as well. That includes centralization and posterior root repair as well. Okay? Definitely you have to do I always do an MRI for all my high tibial osteotomy patients to make sure first whether the lateral side is relatively good. The lateral meniscus is good because I am going to overload on the lateral side. If I am overloading on a torn meniscus, he or she is going to fail, going to go on to rapid lateral arthritis, and patient is not going to be happy even for 10 years. So that's not what I want. And add on information, medial side, how it is, medial meniscus, how it is, and if the patient is affordable, root repair with centralization anchors. So always MRI for all my patients before high tibial osteotomy.
One more, Dr. Sasi. So for ACL patients, for all ACLs, do you check the slope? And if the slope is lacking, do you plan for a concurrent
None of my primary ACL reconstruction patients get slope assessment even because we don't know what is the normal slope. You have made a publication, you are telling me that is normal, but maybe it is not normal for me. We cannot change evolution. If it has been symmetrical on both sides, if the patient has been living with that tibial slope until before the injury, that means that is normal for him. But if the patient is coming for a revision, ACL reconstruction, or in other words, his ACL has failed, even if the slope is normal for him, it is going to put a lot of load on the graft, and yes, we have to correct it. So all my ACL revision cases get slope assessment and slope correction if needed, not my primary ACL reconstructions.
So what is the ideal slope that you work from in a revision ACL?
Sorry?
The ideal slope, the angle, what you aim for?
It's around 70 degrees.
70.
Yeah, nothing is ideal, but we just try to correct it a bit. It's more of a better trying to towards normal. Even the medial opening, high tibial osteotomy, they cannot or need not be ideal with respect to the plumb line correction. But a lot of my patients also go through something called micro H2O. Okay? I do micro H2O, or in other words, minimal correction of medial side for patients who have medial joint tenderness, not much of deformity, but MRI is showing a lot of overload signs, lot of hyperintensity on the tibial subchondral space and femur. Then I have a very low threshold for high tibial osteotomy for these patients as well. Obviously, I discuss with the patients and I give them the option. Most of them accept to have a high tibial osteotomy because that will give prevention of total knee replacement. I hope there are no knee replacement surgeons in this room.
So one more. When you plan for a HTO with ACL and the root type, how will be the order of proceedings? Which, whether you will make the tunnels first or...
First, the diagnostic arthroscopy happens first because we want to confirm everything, whatever we have in our mind with respect to the MRI. So you already have made a diagnosis that there is an ACL tear or a lateral meniscus root tear or a medial meniscus root tear. Then you go ahead with the osteotomy, you do whatever you want to do. That means only medial opening plus or minus posterior, like
exaggeration of tibial slope or correction of tibial slope, whatever you want, you keep doing it. Put the plate, minimal screws, whatever you want to do. Like you stabilize the osteotomy and then go ahead with ACL and meniscus reconstruction. Additional points to consider here is, I prefer plates that allow variable angle possibility, especially when I need to do posterior root repair and or ACL reconstruction. And before I plate those two screws, that is the posterior screw and the anterior screw, I put the tunnel, either way, meaning ACL tunnel drill, I put it there and then I plan my corresponding screw, right? So the anterior screw will come along with a placed ACL drill, so that I know whether I am hitting the metal and I can change the direction. Similarly, posterior root, 4.5 drill bit stays inside for the posterior root, and then I plan the screw for the posterior plate. So stabilization after high tibial osteotomy happens first, and then the repairs and reconstructions in the proximal fragment. The root repair cannot be done in the proximal fragment. It will happen distally, it's okay. It will cross the osteotomy, it's okay, no problem. The ACL reconstruction, sometimes it has come down to the osteotomy side, it's okay, no problem. It's a suspensory fixation, you can still manage. You need not be perfect there. But your vector correction should be perfect. High tibial osteotomy is the primary surgery here. ACL reconstruction and meniscus are add-on.
Thank you, sir.
Okay.
So that is a wonderful presentation. Thank you for explaining high tibial osteotomy in such a good way, and it was more useful. Now we can move on to the next session, the live surgery, which is a all-inside ACL reconstruction by Dr. Prahlad sir. I request Sasinder sir to moderate the session.
Hello, Dr. Prahlad.
Yeah, Sasinder, am I audible?
Yeah, you are loud and clear.
Yeah.
I hope you have not completed the surgery already.
No. So what we have done is, since you were giving a talk, we utilized the time, and since morning sir has beautifully demonstrated harvest, so we just took that advantage and we took a graph. Okay. So now we have just taken stability. It is around 7.5. So what we will do is we will outfit with the gracilis, because we want at least 8.5. 7.5 will be short, so we this 7.5. What do you feel, Sasi? Should we go ahead with 7.5 or we should outfit take gracilis, because I have taken only 70?
Yeah. For me, it should be minimum 8 or 8.5. I agree with you.
Yeah. So we thought that he is a tall guy. So first of all, I have examined the patient. So if you see, there is a anterior drawer project, and also there is mild mediolateral instability. So and he has a Laxton also project, and also he had a pivot shift. Okay. So we did a diagnostic scrutiny. I will show you again after some time. And what I will do is, I will take this part of the graph also. Today morning, sir did the complete removal of the pest, but I had kept it intact. So this is another way you can take the graph. So now, when we do an all-inside technique, we need not take both the graph. So you can just have an advantage of taking only the most of the time that alone will be sufficient for you. But since we had a little thinner graph, I would expect my graph to be at least 8 or beyond. So now I will be also taking graphalis and we will make it as a 6-strand graph.
Dr. Prahlad, just a quick question, just to clarify. So the 70 was quadrupled, right?
Yeah. The meeting was quadrupled and it was 7.5 mm.
Yeah. And I think appropriately the vessel got amputated for us. So it will make all inside possible.
Gracilis is not amputated. So
It looks short.
It is short.
Yeah,
It is
short.
perfect.
So,
It is perfect.
Many has chosen the perfect patient for all inside ACL message.
Yeah. So if you see here, Sasi, we have this almost 26 mm. So the graft is not amputated. You see here.
I didn't see that.
Yeah. So the graft left is complete. So, but anyhow, we will just keep only 12 mm because I want my graft to be only 6 centimeters length. Okay, we just cut it. Don't worry.
But Prahlad, what is your upper limit of graft thickness after preparation?
After preparation, I have done up to 9.5.
Yeah.
And so beyond that, it will really be difficult. So the architects are the only guys who have 12 size screw, and I am the only frequent user of the 12 size screw for TVS side.
Okay. Is it a problem on the screw, or is there a possibility of overstuffing the notch if you go beyond 10 mm?
So that's what I'm telling you. Your patient should be ideal for that. So you should have a tall patient like this. So definitely even your 10 size graft would be okay for that. But if you have a short, stout female, and then I think so we have to think that we should not overstuff it. Okay? And keep it quite wide here. Yeah. Just put that under it.
You can't have a magic figure for everyone, right? So you need to.
Yes, you have
You need to assess it on the patient. You can, when you do the arthroscopy, you will get a picture whether it's a big notch or a big tumor, and the stature of the patient also will help in planning.
So see now what I am doing is, so I am just keeping my graft only to 6.5 mm because when we are planning all inside, so you don't need really lengthy grafts. Okay. So here is like I have put now. So we will prepare the graft, afterwards we will check it. Okay. Take some saline in the bone. Now we will loop it in this. So here again, so this is all inside. So the graft preparation is very important in all inside. So we are using tight rope on both the sides, on the femoral side and tibial side. Okay.
You need to understand that this statement is not for you. I'm just talking to the audience.
Yeah.
You need to understand that when you are planning an all-inside ACL construction, you have to plan the length of the prepared graft appropriately, or you have to plate the tunnels appropriately. The calculation should be in such a way that you should still have a short graft in a long tunnel, then only you can do an all-inside ACL reconstruction. The suspensory fixation both on the femur and on the tibia. If you land up in a longer graft, you will end up not being able to do the suspensory fixation on the tibial side, and you will have to use a screw in addition to having opened the tight rope already.
So perfect, Sasi, what you have told is very important. So when we are doing all inside, there is very less margin of error. Okay, so your graft should be prepared in such a way that so the basic concept of doing all inside is preserving the bone stock. Okay, so rather than preparing the graft, I am just talking to you about the indications why we really need to do all inside. So all inside is basically done in. For me, there are very few indications. It is one of the good options in pediatric cases, and the tibial side you can take. Or you will let it go in femur. So when you are doing all inside, like where you don't want to really damage certain pediatric cases, you can prefer to do all inside, or you can even think of working short scout female where you end up in a very short notches and shallow notch. So they are the again indications for me where you can really do, where you expect a short graft. So your graft will be short in those cases. So I just think of using all inside technique.
So you mentioned about pediatric ACL. So can you just enlighten us a little bit about that? How to be not cross the sizes and how it helps?
So no, pediatric cases only because the graft it will be graft sacrificial only, but the graft diameter we need not take both the tendons, and you really don't need a big graft in pediatric cases. So you can take, and also you can make only one tunnel in this, and that is how you can do it in pediatric. But I haven't done, this is what literature is saying, but I haven't done so far in the pediatric population. So the only indications for me doing all inside would be where you expect the shorter diameter of graft, and also they say it is a bone conserving, so your rehab will be fast. So they try to do it in high demand patient, but I haven't tried for that. Now if you see, we have prepared the graft here. It looks a very little stout graft. I will expect somewhere 10 now. Okay, we are lucky. So 9.5. Okay, so this is 9. Yeah, 9 it is not. It is going very tight. So I don't want to lacerate my graft. So this is 9.5. It is going perfect. So we are doing both 9.5 femur, 9.5 tibia. So they will put couple of stitches here as well to secure the graft. Okay?
I think
so we will go ahead. Yeah.
After he prepares it a bit, maybe you can check the graft thickness again.
Again, and also here these people have the tubes. So I don't know whether Raji we have the tubes. So we don't have the tubes. Here the organized people also have the tubes where you can part the graft in those particular tubes so that the graft doesn't swell up.
Yeah.
Okay. So those tubes are expensive and you can reuse them. Okay.
Yeah.
So now we will go with the diagnostic round. To prepare the graft. Raji, I want you for the colors. So what we will do is I will take you through the diagnostic round here now. So as sir has very nicely described all the portals in the morning, so I have taken the liberty to get away with that. So if you see, sir has not used an 2 portal technique. Today I am doing 3 portal technique. So we have used high anterolateral portal and high anteromedial portal, and I will also use an accessory portal later on. So now this is the suprapatellopubital joint, as we saw in the morning, the small thing, cartilage injury on the lateral side. So this is the gutter. So you can nicely see the lateral gutter here. So this is medial gutter. So this is the medial meniscus, due valgus. So we have broken it already. There is no medial meniscus there. It looks good. And then we saw there is an empty north side. So now you can see there is no brokerage. So it is called empty north side. So there is absolutely no ACL here. So except for this some fibers and there is a prominent tibial spine here. We will try to do a notch plus. We will take out this spine, tibial spine, because it may cause again damage to our reconstructed ACL here. So there is a small cyst in the lateral meniscus. So if you see the lateral meniscus anterior half, so So it looks little frayed here. The anterior horn is little frayed here. Can you do figure of 4? So if we do a figure of 4 here, now we can see again our posterior horn looks okay. So this is the normal mobility of the lateral meniscus. So it looks continuity is okay. So I think so. The lateral meniscus looks okay except for the small vein in the anterior aspect and the small cyst. So we can go ahead and manipulate just ACL reconstruction. What do you feel, Sasi?
I think your plan is perfect.
So we will just give me the shaver. So we have planned for all inside ACL reconstruction. This. I hope your visualization is good.
Yeah, I think it's clear.
It's clear. Okay.
Do you regularly do all inside ACL reconstruction in your practice?
That's what I told Sasi very well. In my practice, I do maybe I have done some 7-8 cases, not much. So they have been only very stout female patient where I expect the graft would be definitely more. So in that case, even you can use your both hamstrings. So basically you can make them 8 stand also sometimes.
I think the approach should be all inside option should be in the armamentarium in your operating theatre, and whenever you have a intraoperative difficulty that you have insufficient graft, and this will be a very good possibility to make for a thick graft. And I just wanted to add on to the discussion about the pediatric ACL reconstruction. Another reason why possibly you want to do all inside ACL reconstruction for children is you don't want to put screws there. So you want suspensory fixation on both ends, because putting a screw there could damage the physis or stimulate the physis. So it can either cause shortening or deformity in either direction, depending on whether it is damaging or stimulating. So
that's another reason, Sasi. So what I'm going to this femur outside deep cut. So we can do femur tunnel conventionally as we do for all the ACL reconstruction. Otherwise, we can do outside technique also. So if you want, I can demonstrate the outside technique, for which we will have to come through the medial portal here. Program this. Angle, if you have seen, we have set 105-degree angle here. So this is the femoral outside here.
So you are planning to clear the jig and do an outside end drilling.
Yeah. So you can see here, this is the jig. We are seeing from the medial portal. Can do little section more, this section. Yeah. So now you can see this perfectly sits over the condyle here. You can see that? You can appreciate? So you can go to this. So what we will do is, so here we have to bring an outside sleeve here. Right. So you have to again fix it once we take this, right? And we mark it.
Okay. Go first. Okay. What is the length there? 40. So hold now. See, now we have kept this jig here, and now we have put a outside sleeve here. So this is coming around 40. So this says that our tunnel is around 40. Okay?
Yeah. Can you show the outside picture, please?
Outside picture large.
Yeah. Okay.
Yeah. Can you give me the?
Yes.
So here now we have to use this special. Again, the outside picture should be here. So this is flip cutter. Okay. So the flip cutter is it drills for your big thing 4 mm, 4.2 mm, and then you can open the. If you can see here, so this we can open the blade how much ever we want, and we can drill the tunnel in a single go. So see now if I have set it to 10 mm, so I can drill the 10 mm tunnel. So this is 9 mm and this is 9.5 mm. So my aim will be to do a 9.5 mm tunnel on femoral side. Okay, so now again I close this. So this is 3.5 mm. Now it is closed. So we will go ahead and drill it. Okay? So
Yes.
this is okay. Be careful. Okay? Slowly.
As I said, the margin of error in all inside is very low.
Yeah.
The jig should not move.
Now hold it. Hold it.
We need very good assistance.
Yeah. Go ahead.
Yeah, I was just saying the margin of error with all inside ACL reconstruction is very low. Like the assistant should be holding the jig like a statue.
So as Sasi was telling,
Okay.
we got that good, huh? So now I can just take this, take this down, but we should not take the sleeve out. We can highlight it. Yeah. So make this fixed, okay? So now bring this black dot. You can see this black dot?
Yes.
Huh? Yeah. So we will bring it to the end here. Okay? Let me do this step. So this is again a very critical step here.
Yeah.
So we will see this. We have 3.5 here. So now I will keep on increasing it. So this is. So maybe I have to withdraw it little. Then only it will. Okay.
Show inside pictures. Yeah.
Okay. So now this is 3.5. Okay, the soft is more material.
Just a probe to.
You can give me a probe or something. So these are all sometimes difficulties you get when you do all inside techniques. You have to be very careful. Can you should come outside little. Okay. Okay. Yeah. So see, there is a bone deposit here. So we need to clean this. See whether you are able to open. You need to open. Open all done. Yeah. Open 7, 7.5, 8, 8.5, 9 and 9.5. Okay, so now we have opened 9.5. Okay, can you see here? So this is 10 now. So I will reduce one. So 9.5. Okay.
Yeah.
So now we have reverse. Anything for doing reverse? Yeah. So we will go reverse. So hold the thing. So here again it is very important that we should take out 20 mm. So you should again see what point here the black mark is.
Inside pictures.
Inside picture, you can put some shaver there.
This is again a very critical step. We should not dock it on the femur and rotate it. We should start rotating and then slowly dock on the femur. Right. Otherwise the blade can break.
Take out that light. Let me see here. Yes. So now we can see here. So we have 15 mm. So I will just take. So now I am. So we have taken around. Now it looks 3 centimeters here, but before there was 1 centimeter. It was outside. So now we have made 2 centimeters. So now again I go forward. Okay. Okay. Shape please. Can you come and hold on here? This is just for demonstration. I am doing this technique. Otherwise, you can do our conventional technique only. That is also equally you can do it. So you do this again. Okay, just hold it up.
You also have the option of doing an inside out drilling on the
that's what I am telling. You can always inside out. So this is only for demonstration. We are doing this, but it is always safe and better you can do from the inside only. Okay?
And then you can use a flip cutter for the tibia.
Yeah, flip cutter for the tibia is good. See now, we have made a good tunnel. You can see here. Okay? So we still have not reached any posterior wall. So now we can close the flip cutter. Close the flip cutter. Completely closed. So the 3.5 mark is achieved. Now take it reverse. And now pass the switching stick. So this is the switching stick which comes. Hold this. Give me an ice stone or something. Hold ice stone. அப்படியே வச்சுக்கலாமா இல்லைன்னா okay. Now we can extend and also you can see. Okay. So now super. You can see something.
Yeah, beautiful.
So we are good with the femur tunnel. Now we go again switch the portal. So also you can see from here inside the tunnel. Okay. So this is the entire tunnel view you can see. Okay. So our tunnel looks good. Yeah. We have around 50 mm of tunnel.
Yeah, the benefit of all inside is to have a round aperture, circular aperture. instead of an oval aperture.
Very good. So now we go to the tibial tunnel. So here again, I will just take out the this here. So as sir was telling morning, we have to take out all the debris here. Okay, take out all the debris. Whatever more debris are there. Okay, so this bones like we have a bulb, but we use it after making the tunnel. It will still stay there. Okay, sometimes it may go in the tunnel also. So give me the chip. So we will use the same footprint chip here. So we did not do any accessory material portal. So we got away just doing this. So again, landmark for me would be 8 mm, anterior to the PCL, so somewhere here, or it can be just medial to your lateral horn of anterior horn of lateral meniscus. Okay? Yeah. So again we got around 40 here. Can you hold it? Yeah. Will be the flip cutter. More enter. Clean பண்ணியாச்சமா? More enter. I think so we'll take it.
It's good to, I'm just discussing with the audience, it is good to have many ways of building the cat, or in other words, identifying the footprint of the ACL on the tibia. So one way, as Dr. Meghlad said, is millimeters, so many millimeters anterior to the PCL. I have not been able to identify that very well, but lateral meniscus anterior horn is a very good landmark. The ACL attachment is medial and posterior to that. Even better landmark for me is ACL footprint is exactly in between the two tibial spines. Basically, there is a crater. These are two mountains and there is a valley inside. ACL comes out of that. But the problem is when there are cases where the tibial spine is very hypertrophic or prominent like this, that space appears to be very small, and when you use a burr or something, or you can just aim it there and use it till the tibial spine can rid out of it.
So, are you okay with the position of entry, Sasi?
Yes.
So now I am opening this flip cutter. So around 8.5, 9.5. Okay. So I have opened 9.5, and now we go reverse here. In the reverse the chapter. Reverse. Okay. So again, as Sasi was telling, you should your assistant should hold it tightly. See now this itself is taking that osteophyte. Okay, so the osteophyte got moved there. So now we have to make sure that we do something around 25-30 mm. Okay. Okay.
How much of bone are you planning to leave behind on anterior cortex?
See now, when I was drilling, my tunnel was somewhere around 35 to 35 mm. Okay, so there is always some margin of error. See what we normally tell 20 mm graft goes in the femoral side and 20 mm remains in the joint and 20 mm on the tibial side. So sometimes we may either we have what is the exact length of the graft 6.3. So to accommodate this, we need to have some breathing space. So this breathing space I would like to take it on the tibial side.
Okay?
Yes.
So on the tibial side, I make it up to 3. So here we make it up to 3. On the femoral side, we made up to 2. So we will be able to accommodate around 6.5 mm graft. Okay? Okay, Sasi?
Yeah, okay. And we need to assume the intra-articular length of the graft based on the stature of the patient. It can be somewhere from 1.5 to 2.2 or 2.5.
Yeah.
So if it is a small patient with a small knee, possibly it is going to be on the 1.5 side. A huge patient is going to be on the 2.2 side. So that also needs to factor in calculating the length of the tibial drilling. So end of the day, you want tibial socket that is not too short and it is not too long to break the anterior pockets of the tibia. If it is too short, the ACL graft is going to be docking already and it will be lax. The ACL graft should not dock on the socket in the tibia. It can dock only on the socket on the tibia.
Pull up. I need an MP. Now that pipe has gone, okay? So we thought of removing it, it has tunnel only has
Threads has a special equipment like a file that can be fit into the handpiece for solving these bone prominences.
Can we put it in a good thing? I think so, we are good. Okay. Just take the mouth of the tunnel here. Okay?
Yeah.
Take this. Grab the head of the correction. And the sound tissue get the we have passed 2 threads separately. Okay? So one is for the tibial side here, we have separate, and one for the femoral side. So here the graft will go transported. Okay? So I have to increase the graft size. The portal size. Deep knife.
I can see the tibial side loop, but where is the femoral side loop?
Femoral side loop, maybe can you show him? Just, can you see that?
Yeah, but it's not retrieved through this side, okay.
Yeah. So it is there, I will take it in the portal, but before I just want to increase the size of the portal.
Right.
Because the graft goes through this portal, then hardly. Yeah. So now, either you can use the passport cannula here. Okay?
Yeah.
You can use a passport cannula, and it will be this one. If you can remove that one.
The graft will be going into the joint through the medial portal, so we need to retrieve both the loops through the medial portal without soft in between.
Yeah. So we have to make sure that hold this scope. So now I have these 2 loops. One is the tibial side, hold the other end, femoral loop. So I will, as the Sasi was pointing out rightly, I am passing this to make sure that there is no soft, there is some soft tissue now in between. So which can cause some problem, but now it is clear. Okay, Sasi?
Yeah, perfect. And Dr. Brenner has also opened up the portal a bit in order to then allow double graft. The graft will be going in as double.
So first we will railroad the femoral side, and then we will have to take the tibial side also.
You first graph versus a single thickness. We first pull on the thinner side and then we pull through the tibials. But with all inside, you cannot shuttle the scope into the medial portal to see the tunnel.
Yeah.
On the femur.
That's why I'm just asking if.
Because the graft is also going through the same portal, so you cannot put the scope through the same portal. But with regular hybrid, you can kick the graft through the medial portal because the scope through the medial portal because the graft is going through the tibial tunnel.
So I'm just again, as Sasi was telling, I'm just cross-checking my tunnel. Is it okay, Sasi? This is femoral tunnel from medial right? Okay?
Beautiful.
Now we will do one thing. We will just come again to the lateral visualization. Grab. Be careful. Situation, okay, the graph has, the button was stuck in the graph board. So here, okay, can someone show me the graph there? If you hold it, it is there. Give a second. Okay, come this side last. Okay, so this is the femoral side, okay. So we have marked up to 40 for the size of the tunnel, and this is 20 for the tunnel socket. Okay, this is for the socket, and this is actually 20 we have marked here, so that we expect that to be the graph point. So, okay, again, wonderful. Then we hold the scopes. This is graph. Full mark. So now I will try to show. Okay.
Someone has to be holding the graph like
Yeah. So we have Guna is holding here the graph without making it touch to the skin. So now the endo button is going in. Okay. Pull the blue one. Pull the blue one. Pull the blue one. Pull the blue one. Okay. So now we have reached the mark here. Okay. So I think so it is flipped. So now here I will put my finger here so that our graph doesn't get stitched. No, you should go again. Go. Pull please. Pull up. Where is we are not able to see. Okay. Yeah. So now still so always pull and see yourself. Don't rely that he told me 2 times that graph is flipped, the button is flipped. So I kept on pulling. So now I am sure that it is not coming out. Okay. Now you can see the graph. See the graph. And then we will take it on the tibial side. Okay? Yeah. So, okay, enough. Hold this scope, someone hold this scope. Okay, see now, give me this loop. So now outside picture.
The cinching over on the lateral side.
Femoral side we have done.
Yeah.
So now I am pulling the button on the tibial side. Okay, the button has gone inside. So it has to come to the tunnel now. Length in the lava.
These steps are also very important. The loop has to be lengthened already.
Yeah.
In order to be able to come out.
Okay. And give me some. You won't pull the white one, okay?
And one more thing I do when pulling the tibial side is give a sudden quick movement on the tibial side. The button doesn't have time to think and get locked inside the tunnel. Okay? The tibial side pulling has to be jerky.
Put a retractor here. Yes. One இன்னும் length பண்ணிருக்கலாம் இப்போ இன்னும்
So you see arthroscopically the button going to the portal, and then one it is pointing in the tunnel. Give a quick pull, the button will come out. If the loop length is
So we got that.
The loop length is
So now you can see that the graph is nicely seated. Now we can see this button here. Okay. So now we will just do cinching again. Cinching on this side. That is already 20 now. So we can leave. Cycling we will do. Yeah. So just is it okay, Sasi? So now you can see. It is looking good. So we will just do some cycling here.
You can loop on the button when you are cycling.
So if you, as Sasi was telling, we can loop on the button also. So can again slowly rinse this. Here, put retractors. Yeah, put retractors. Put retractors. Yeah.
This step is also very important. You should be able to see the bone, see the button.
See now, this is very important. So you should make sure that the button is perfectly seated. Okay? So you can see button is perfectly seated, tight, flush. Can you show this please? Yeah. One more retractor please. Can you see that, Sasi?
Not yet.
Yeah. Now?
Beautiful. Yes.
No, see, you can see that it is tight and flush. Okay. So now again we will go inside the joint. So now you can see the stability. It is rock solid. Yeah. So now we can do cinching on both the sides as needed. Okay, give me the probe. Can cinch this. Give me the probe. Okay. Cinch on the femoral side first. So there is some the same. Yeah. So now once the femoral side is cinched, you can see the graft has become down. Okay.
Also, the knee is in 90 degrees, so it is expected that the graft will be a bit lax.
Yeah. So that laxity is there. So we can just extend and check also. So there is absolutely no, I am hyperextending, so no notching. So there is no risk of any screw or this thing. So I don't have to do any notch plasty or anything here. Okay. So now you can do a little bit of tightening there and tightening here. So I usually put stitches, knots on the tibial side. Okay. So we can just put couple of okay. Again, flex please, flex. Flex.
You can show the outside picture, please.
Yeah, I will show both outside in a while. So now this is the inside.
Yeah, inside.
So you can, yeah, that's okay, Sasi.
Yeah,
you can see.
Beautiful.
Yeah, very nice graph. I will just take out this little bit of previous graph which was there. So these are bone preserving technique. All inside is a bone preserving technique. Okay, so it does take little bit of okay. Give me RF. Okay, that's okay. That's good. So, I think so. I'm happy. How about any questions, Sasi?
nothing else.
So we taught today both the technique, the conventional technique and all inside technique. So I think so we can be judicious in selecting for our patient. So this is bone preserving technique, and you can use it whenever there is a shorter diameter where you expect a smaller diameter graft. So you can use this.
Yeah, correct.
Okay.
Beautiful.
Anything else, Pratik?
Any questions
Money?
from the audience?
Okay.
I think everything is very clear.
Yeah. So I will sign off. Thank you.
Thank you so much, Dr. Pula.
Thank you, Mani. And again, I thank the entire team, our anesthetic sir, the entire team at the East Coast Hospital, Shekhar brother, Rachi, my fellows, Ebin and Guna has come all the way from Madurai to help. Avinash is there, Raja is there, and the entire staff, Siva, audio team. I thank them all for all the help. Thank you, Ma.
Thank you so much. Thank you, Dr.
Thank you, sir. So you can see the medial lateral is also reduced. Okay. Not spoken.
Thank you, sir, for that excellent live surgical demonstration.
Yeah.
Your step-by-step explanation and practical insights into all inside technique for ACL reconstruction has made the session highly informative and valuable for all of us. Moving on to the next session on posterior cruciate ligament and multiple ligament knee injuries, I now call upon stage Dr. Adil Kumar sir to talk on PCL reconstruction.
Thank you. ஒரு போட்டோ எடுத்துக்கலாமா? வாங்க. ஒரு போட்டோ ராஜ். போட்டோ மட்டும் எடுங்க. ஷேர் பண்ணுங்க.
We'll start off with PCL reconstruction. The indications are when should we operate PCL? Not all PCL injuries when you see in the MRI needs to be operated. So the grade 1, grade 2, which shows up to 10 mm of translation, can be managed with bracing and proper physio protocol. So the reconstruction is only when the translation is more than 10 mm, and if there is a failed conservative PCL injury, and if there is associated with posterior ligament complex and multiligamentous injury. So the contraindication, whenever there is a malalignment of the limb, and when we are planning for multiligamentous cases, we can do it in a staged manner. So the timing, more than 12 weeks, it is said that there is a high chances of meniscal and cartilage injuries. So ideal time is less than 12 weeks, if at all it is a proper indicator for surgeries. And you give some time, about 2 to 3 weeks for the swelling to come down. So regarding the footprint, femoral footprint, we know that there are two bundles, the anterolateral bundle and posterolateral bundle. So the length is about 32 to 38 mm, and it's quite large, 1.5 centimeters, 1.5 times larger than that of the ACL. And the anterolateral bundle is twice than that of the posterolateral bundle. So it is up to 20 to 30 mm, and you can see it is very close to the articular cartilage, and even it extends up to the roof of the notch. So the tibial footprint is quite broader, giving the appearance of hourglass shape, as its insertion is 3 times more than that of the body. The attachment in the tibia roughly goes about 1 to 1.5 centimeters below the joint line, that chamfered glass drop. So regarding single bundle versus double bundle, the clinical outcome has no such differences. But whatever said, the sports athletic patients need to be done double bundle reconstruction, but conventionally we all do single bundle reconstruction. So the graft options, there is no ideal graft for PCL, but the minimum graft thickness has to be at least 9 mm, and it's the surgeon's preference for the graft choice. So we have PTP graft, hamstring, quads, peroneus in the autograft, and allografts are also used in the worldwide. So positioning is the standard positioning which I use, supine with 70 to 80 degrees of flexion with a side support and a sandbag under the pelvis. So examination, You get to see the posterior drawer with the sag. On-table assessment is definitely required. So as you can clearly see, this is grade 3 with the posterior sag. It was associated with the MCL injury also. So the standard portals, the anterolateral and anteromedial portal, we view with anterolateral portal, high anterolateral portal and anteromedial portal, and we make a posteromedial portal where, under the guidance of arthroscopic light source. There are also surgeons who use a high posteromedial portal for viewing and a low posteromedial portal for working, for better visualization. So use of cannula in the posteromedial is very essential in order for the instrumentations. So the initial arthroscopic finding, this is in a case, shows the tibial attachment PCL injury, and the remnant stump is being debrided using shaver and RF, and the posteromedial portal is being prepared with the help of an outside-in technique with the needle, and the artery is introduced to open it, and the cannula is inserted, followed which the shaver or RF can be used to prepare the tibial bed. So this is a special PCL guide which we use, which has an anatomically contoured, which can negotiate the ACL and enter into the posterior tibial condyle. With a 50-degree angle, we tend to drill the guide, and it also has a groove which protects the neurovascular bundle when at the time of drilling. So the tibial PCL guide is introduced under visualization. We all know what is killer turn. So the ideal drilling angle, it is said that 30 to 45 degrees is essential in order to avoid the killer turn, the acute turning of the graft, in order to cut out at the later stage. But as you increase the angle, that is more than 45 and it goes to 60, the only problem is you don't have a good bone quality. So the ideal will be about 45. There are also surgeons who use a check X-ray intraoperatively just to confirm the correct positioning of the tibial side. And the tibial tunnel preparation, while drilling, we can make use of a scoop or something in order to hold the guide pin and then start drilling to avoid the neurovascular injury. And the tibial tunnel is prepared. So you pass the bead pin through the portal and you retrieve it through the posteromedial portal. And the femoral tunnel, now we come to femoral tunnel preparation. So we are aiming at the reconstruction of the anterolateral bundle. So the target is fixed, and you pass the guide wire at the anterolateral bundle site, and you drill it with 4.5 mm drill bit through and through as like ACL femoral tunnel. You get the measuring, and the normal measuring would roughly around 38 to 40 mm. And then you start drilling for the inner tunnel, which usually up to 20 to 25 depends on the surgeon. You clear away all the debris at the femoral side. And you pass the bead pin through the femoral tunnel for the thread shuttling of the graft. Now the already passed tibial tunnel along with this both are retrieved, and it is brought out at the anteromedial portal, and it's kept outside. So next step will be is to pass the graft. So in order to avoid this acute turning at the tibial platform, we use a Riesinger rod in order to guide the graft shuttling. So you can see the endo button getting pulled, and you just make sure after the endo button is flipped, it is being guided properly. You can see that it is flipped now, and the graft shuttling has to be done in a very controlled manner. As I always do it with the two arteries holding at the threads, and with the help of Riesinger's rod, just guiding the graft. And you can see the graft is pulled up to the mark. Yeah? And the tibial side fixation usually, so that was a suspensory fixation of the femoral side, and the tibial side fixation will be mostly a screw, and after cycling of the graft, it is fixed with 30 degrees of flexion with the anterior drawer force, which is given. So the chances of the graft lengthening after the PCL gets healed, leading to laxity. So the secondary fixation is advised with either a washer or a post. So the difficulty in PCL reconstruction, what we normally see is the visualization. In case you have an intact ACL, then the visualization becomes little tough So you can use a 70-degree camera in case you have, which is not available so quite often. So they use two posterior portals, a high posteromedial and a low posteromedial portal. So the graft passage difficulty is there. You can make use of the rod as shown in the video. And in order to avoid the neurovascular injury, to maintain the flexion up to 90 degree during the drilling is essential. So strict rehab is advised. Whenever you are using a bone graft, then the bone-to-bone healing takes up to 6 to 8 weeks, and soft tissue healing takes up to 8 to 12 weeks, which is quite longer. So always the guarded PCL support is needed up to a month. So prolonged bracing is usually needed for him. So avoid hamstring activation in the initial 2 months of post-operative. So hamstring activation needs to be avoided, and prone ROM is the exercise that needs to be followed. So laxity is being, after the healing of the PCL, there is a residual laxity. It is being shown with a lot of evidences as of now. So the take-home message is, whenever you see a PCL injury, grade 1, grade 2, give a trial of conservative management. Always you can do PCL at a later stage until they have an associated multiligamentous injury. So the early surgery is indicated, less than 12 weeks. And the single bundle reconstruction hold good with the clinical outcomes. The graft choice is surgeon's preference as per your, but the minimum thickness needs to be 9 mm and the strict rehab needs to be followed. Thank you.
Thank you, sir. Your detailed explanation on the surgical principles and rehabilitation considerations greatly enhance our understanding for this complex procedure. Now I call upon stage Dr. Dinesh, sir, to talk on PCL avulsions. He is a clinical director of orthopedics at Meridian Hospital, Chennai, assistant professor at Shri Lalita Bigai Medical College and Hospital.
Very good evening, everyone. So, my name is Dr. Dinesh Chaudhary. I'm here to talk about the PCL avulsion fractures. I work at Meridian Hospitals, and I'm also a visiting professor at Sri Lalita Bigai Medical College. So, first we'll start off with the anatomy of the PCL. So, if you see, the PCL is one of the strongest ligaments in the knee. The strongest ligaments in the body is, of course, the iliofemoral ligament, the ligament of Bigelow. But when it comes to the knee, it is the PCL, which is the king of all ligaments. It has a tensile strength of almost 2,000 newtons, and its primary function is, it is a primary restraint to posterior tibial translation, secondary to valgus, varus, and mediolateral and external rotations. So, coming to PCL avulsions. So, this constitutes 3 to 5% of all PCL injuries, and it is bimodal, meaning it comes in young athletes and also following high energy trauma. And tibial avulsions are much more common than femoral avulsions. And if you see exactly what we mean by avulsion, the ligament remains intact and only its bony attachment is avulsed. This makes anatomic fixation the most ideal surgical solution. So coming to the mechanisms of injury, the most common is a dashboard injury, where the knee is flexed at 70 to 90 degrees and the force is applied anteriorly. And it also occurs in athletic trauma and sports injuries, where there is a hyperflexion mechanism and also enforced hyperextension injuries. Clinical presentation, patient presents with pain in the posterior aspect of the knee. There will be hematoma, tense hematoma swelling as well. And as in PCL TAS, there will be a SAG sign positive, posterior joint will be positive, and interrelation sign will also be positive. And always mandatory to check for neurovascular deficit, any neurovascular injuries also. Coming to imaging protocol, it's sometimes be difficult to pick up these injuries on plain X-rays. You might have to look for a stress X-ray, and MRI is always the gold standard for evaluating the PCL avulsion fractures. CT scan, if you're going for operative, it is a must. The CT scan is done, especially look for a 3D reconstruction of the knee joint, which is mandatory for pre-op surgical planning to assess the cortical fragment continuity and fragment quality, whether there's any comminution or not. CT scan also help us in classifying this fracture. So we follow the Mayer's and Dickiever classification. Type 1 is undisplaced, less than 2 millimeters of displacement. Type 2, there's more than 2 millimeters of displacement. Type 3 is completely displaced, and type 4 is comminution of the fracture fragment. So this classification can be done only with the help of a CT scan. So that's why we recommend taking a CT scan before we plan for surgical procedure. Coming to the mode of management. So we plan for conservative management only in type 1. In type 2, type 3, type 4, there's no role for any conservative management. So type 1, when the displacement is less than 2 millimeters. And in pediatric cases, or if the patient is unfit for surgery, then we can go for a conservative management where we brace the patient. For first 2 weeks, the acute phase, we don't allow any weight bearing. We allow only non-weight bearing with crutches and no knee range of motions. Phase 1, that is immobilization phase, the 2 to 6 weeks, we allow the patient to weight bear from 4th week, and we allow knee range of motion only 0 to 30 degrees. So 0 to 90 degrees we allow after 6 weeks, and only after 12 weeks we allow the patient for other return to sports or sports specific training. After we do the functional assessment test and posterior stability test, if we are happy with that, then we allow the patient to return to sports, which is usually after 6 months. And with this conservative management, 75 to 80% good to excellent results are seen. And if it's a type 2, then there's always a 30% risk of residual laxity. That's why we always recommend type 2 to type 4 patients for surgical options. Surgical indications, as I said, absolute indications type 3 and type 4, type 2 also with more than 5 millimeter displacements, irreducible fractures, multi-ligament injuries, they are all absolute indications. Relative indications is type 2, high demand athlete, and chronic instability for more than 3 months after type 1 injury, or a combined PCL plus a posterior corner injury. These are all relative indications for surgery. And surgical timing, the best time to do is less than 2 weeks. In the acute stage, when the fragment of soft tissue attachment is preserved and easier to get reduced. In the subacute phase, 2 to 6 weeks, it can still be done. There will be scar tissue beginning to form around the fragment, but it's still feasible to do the surgery. In chronic cases, more than 6 weeks, you might probably want to do an open approach rather than an arthroscopic approach. And if the fragment is not viable, we might have to consider a PCL reconstruction. Fixation options. The gold standard is arthroscopic, not a screw fixation. It's not down nowadays. We prefer arthroscopic suture fixation with ABS endo button or a transosseous bridge technique. We can also have a suture anchor fixation as backup, and open posterior is preferred when there's a failed arthroscopic or in chronic cases when the fragment is not viable. Instrumentation before the surgery, always be prepared, have an arthroscope and have a PCL current rasp for the fragment bed preparation, have drill guides and drill bits 2 mm, 3.4 mm drill bits ready, and a regular PCL drill guide as explained by Dr. Adit in the previous presentation. We can have that also ready, and have candidate cancel screws as backups in case anything goes wrong, and suture anchors also backups. And a pituitary roger is, I prefer using that for soft tissue clearing around the PCL attachment site. So, as I said, candidate screw fixation can be done. For us to do a candidate screw fixation, the fragment should be greater than 1 centimeter in any dimension. There should not be any comminution. The bone quality must be good, and anterior to posterior trajectory should be possible. Only if these are possible, we should opt for a candidate screw fixation. Otherwise, it's best to go for an arthroscopic suture transosseous fixation. This can be done in even small comminuted fragments, even in pediatric or osteoporotic bones, and even in a failed screw fixation or high PCL attachment where there's a peel-off type of pattern. This technique is very useful. Post-operative care, I always use a PCL brace locked at 0 degrees for 2 weeks, even after surgery, and non-weight bearing for up till 4 weeks. After 4 weeks, I start the weight bearing, and X-ray again at 6 weeks to confirm the union. And complications, malreduction, non-union, we should remember that even with after surgery, 8% of chance is there for a non-union. Arthrofibrosis can occur, where there's early range of motion is, we recommended at least we start the range of motion after 3 to 4 weeks. And risk of neurovascular injury is there. residual laxity can happen, it's about 10% even after surgery, and there is also, remember, there's a 2 to 3% chance of DVT. So always in all these cases, PCL cases, start your DVT prophylaxis immediately after the surgery. Evidence-based outcomes. After surgery, the union rate is about 94 to 98%, and the stability is restored at 88 to 95%. Return to sports can happen after 6 months. It's almost at 85 to 92%, with good to excellent outcomes. This is a small video, which is a technique that I use. We can take the bites using the suture passer, first pass or a scorpion, depending on which company implant you prefer. So this is the view from the posterior portal, where we're taking bites on the PCL ligament using a fiber wire, and this fiber wire is usually passed below the tunnel that we have created here. We use a proline to pass the sutures through that, the fibers through that. So at this place, the pituitary launcher that I mentioned will be very useful for doing the soft tissue clearing, and always have a radio frequency for this, RF ablator for this. And once you have built the tunnel, it's also advisable to use the CR to check the position of the tunnel to see how anterior or posterior or the midline the tunnel is. Here is a post-op X-ray with a button fixed in with a rehabilitation program. I've already mentioned this. So we can start strengthening after 6 weeks. Full weight bearing by week 8 to 10, and full range of motion is 135 degrees. Flexion is ideal, and you can even start it. One thing that you have to remember is open chain hamstring curls. These have to be avoided till week 12, and prioritize closed chain quad dominant exercises, proprioception and balance board week from week 8. And if you have hydrotherapy available in the center, it will be very useful for range of motion exercises. So these are evidence-based clinical outcomes based on the arthroscopy fixation, open fixation, and conservative. You can see arthroscopy fixation has a very good union rate of 94 to 98%. The residual laxity is around 5 to 10%, and ROM recovery is the best with arthroscopy fixation. Return to sports is also the best with the arthroscopy fixation, and these can be done even as a day cash procedures. The key take-home messages. First, PCL avulsion fractures are distinct from mid-substance tears. Don't treat them like tears, you have to treat them like a fracture. The ligament is intact, making the antapping fixation the most ideal solution. The classification type 1 to type 4. Type 1 can be tried conservative, type 2 to type 4 mandatory to consider surgery. And CD reconstruction is a must when you're planning for surgery. We prefer for a 3D reconstruction of the knee joint, and MRI is also a must to rule out other coexisting meniscal or other ligament injuries. Arthroscopy fixation is the gold standard because it has less mobility, excellent visualization, superior cosmetic, and can be done as a daycare procedure as well. And posterior portals are very critical. Transeptal posterior portal for direct PCL footprint access, and we have to remember to protect the popliteal neurovascular structures while doing this. Rehabilitation is PCL specific, and open chain hamstring curls until 2 weeks should be avoided. Quad dominant should be the protocol throughout. Functional bracing for return to sports. And outcomes are very good with 94 to 98% union rates. Return to sports can happen at 6 to 9 months. And results are superior to conservative management for displaced fractures and arthroscopies. Thank you.
Thank you so much, sir. That was an excellent session on PCL avulsion injuries. I now would like to call upon stage Dr. Manikandan Adimulam, sir, to talk about multiligamentous knee injuries. Professor and Head of Arthroscopy and Sports Medicine Unit in Sri Venkateshwara Medical College and Research Center.
Good afternoon, everyone. So we have come to the last session of the talks. So just to brush about the multiligamentous knee injury, so the PGs can have a slight idea. Okay, so what is multiligamentous knee injury? Definition where the injury involving 2 or more ligaments of the 4 main ligaments around the knee, and it is quite common, synonymous with the knee dislocations. As of incidence, the reported incidence is 0.2%, 0.02%, which is very less, but most likely this incidence is very underreported, and because 50% or more cases spontaneously reduce and most often missed. So commonly any knee dislocation, you have to suspect a multiligamentous knee injury. And mode of injury is usually a high velocity injury, high energy RTA, road traffic accidents. And in sports, you can even have a low energy injury which can cause multiligamentous. But whenever the patient is obese, even a small twist or an hyperextension injury can cause multiligamentous injury. And whenever you have a knee dislocation, the associated injury is very common, mainly the vascular injury, which accounts for around 18 to 64%, and your CPN, common peroneal nerve injury, which accounts for around 25%. You can have an associated fractures, soft tissue injury like a tendon rupture or a periarticular avulsion, and a meniscal injury. So coming on to classification, the Schenck classification is commonly used, where you have 5 types. KD1, that is type 1 is with either cruciate intact, type 2 is bicruciate injury with collaterals intact, type 3 is bicruciate injury with either one collateral torn, either the medial side or the lateral side. Type 4 is bicruciate with both the collaterals gone, and type 5 is associated with periarticular fracture dislocation. So this classification is usually used in management and treatment. So initially, how do you evaluate? So first, in case of any high velocity injury, you should have a high suspicion for multiligamentous injury. And once there is a dislocation, the knee joint is gently repositioned, and then you have to go for your vascular and neurological assessment. The radiological evaluation comes next. So immediately on presentation, immediate reduction is done by gentle traction and extension, and followed by a detailed ligamentous injury examination if the knee is stable or if it doesn't cause much pain. If it is stable, gently immobilize the knee in mild flexion or a long knee brace. If it is unstable, then you have to plan for an external fixator. So this is how you do a close reduction with mild traction and reduction, and you have to splint the knee in 20 to 30 degrees of flexion. So post reduction, again you have to do a X-ray to see for any bony injury. CT can be done, and MRI is usually advised to rule out or to confirm the ligamentous injury. And you have to monitor the ABI and ankle brachial injury for at least 72 hours to see for vascular injuries. So what is an ABI? It is the systolic blood pressure of the injured limb divided by the systolic blood pressure of the uninjured upper limb. So whenever your ABI is less than 0.8 or less than 0.9, then that means there is a vascular injury. So you have to usually go for a angiogram. Anything more than 0.9 is acceptable. So when all do you need an emergency procedure in case of knee dislocation? Whenever you have a open injury, whenever there is a vascular injury, whenever the dislocation is irreducible or unstable, or it is an unstable fracture dislocation, and whenever there is an associated compartment syndrome. So this flowchart gives a vague idea. So whenever the patient presents with knee dislocation, always check for the knee pulse first, distal pulse, and try to reduce the knee. Once if the knee is reduced, check whether the knee is ischemic or well perfused. If it is ischemic, then you take in for a vascular reconstruction. If the pulse is present, then you have to monitor the ankle brachial index. If it is more than 9, then observation. If it is less than 9, then you go for a CT angiogram. If the pulse is absent or asymmetrical, again CT angiogram is recommended. So any vascular injury, first reduction and external stabilization is mandatory. So other indications for external fixator are your compartment syndrome, compound injuries, unstable reduction, and in obese patient, and whenever there is patient is a patient of polytrauma. So next comes the acute phase, that is more than 72 hours after the injury. So in this stage, you can have a detailed examination for ligaments injured, and you can plan for a surgical repair or reconstruction. So next comes when to do ligament reconstruction, what to do when the patient comes less than 3 weeks or delayed when of more than 6 weeks. But never, in the case of multiligamentous injury, go for conservative management because the results are poor, and persistently the knee goes for instability, or on the other end it can go for stiffness. Again, your Schenck classification is what your treatment is based on. So coming on to early repair, this is done within less than 3 weeks. So the advantages are your soft tissues are well defined, and you can have a possibility of repair in case of your collateral ligament tears, and the knee kinematics can be restored very early, and further cartilage damage can be prevented. But the disadvantage being arthroscopy is very difficult because of the hemarthrosis, and patient most of the time are diagnosed to have arthropfibrosis or stiffness in case of early attempt. So early surgeries are recommended in case of bony fractures, any avulsion injuries, or in grade 3 injuries of the collaterals, where you go for a repair or augmentation, and sometimes when you need a meniscal procedure. So this is how, when you see the patient in early phase, either you can do a single stage repair and augmentation, or a single stage acute repair of the collaterals and followed by a subsequent second stage of arthroscopic reconstruction, or acute immobilization and a delayed repair and reconstruction of the ligaments. Delayed reconstruction, the advantages are better ROM. Some structures may heal, like the collaterals. Whenever you have a grade 2 injury, it can become a grade 1. So you can prevent from reconstructing or trying to reconstruct all the ligaments. And disadvantages, your repair is not possible because all the tendons would have fibrosed, and reconstruction is the only thing. And there is a period of immobilization which we need to follow. That so again, there is a delayed recovery. So again, in a delayed stage, the first comes the bony correction, where you have to correct all your bony alignments. Then usually your collaterals may heal on itself, and if it is still not healed, then you go for a reconstruction. But your cruciates usually need a reconstruction, mainly your PCLs. So this is again your staged procedure. You can do ACL or ACL reconstruction and extracapsular LCL repair. So this is a flow chart for managing the chronic ligamentous injury, multiple ligamentous injury. So complications are, as we discussed, the vascular injury, which accounts for 25 to 60%, and peroneal nerve injury, which accounts for around 25%. The treatment is foot drop splint, and in acute cases, when it is completely torn, then you can go for a nerve repair. In chronic, then you go for a reconstruction or a tendon transfer. So the take-home message, you have to have high suspicions in case of high velocity injury. If it is less than 72 hours vascular injury, you can do a vascular revascularization, external fixation and monitor. Less than 3 weeks, fracture fixation can be done, avulsion injuries can be fixed, and a single stage repair can be done. More than 6 weeks, you evaluate the bone and fix the bony malalignment first, followed by ligamentous reconstruction. Thank you.
Thank you, sir, for that comprehensive and highly informative session on MLKI. And I kindly request you to...
I thank all the delegates who have come, and all the faculties who have come for this presentation. And I thank the AV people for helping me, and Arthrex for making arrangements for this CME. Thank you.
I request Dr. Manikandan sir to felicitate and give the memento to Dr. Dinesh sir. Thank you everyone for being here and